Okay, it's fine.
Okay.
So everyone, Happy New Year. I think that we'd like to start the sixth Bosnia and Herzegovina and ACNS and joint conference. So I think maybe we can have a great exchange last the 5 times among Balkan Peninsula, Balkan countries. I think so. This time we have so many excellent, super speakers. So I think we can have a lot of study. So Dr. Raja and Dr. Liu, shall we start?
Yes, of course, ma'am.
Yes,
Liu?
please. Yeah. Liu, you want to say something?
Yes.
Please. So you want to say something? Okay, so then we can start. Professor Rao, are you ready to talk?
Yes, madam.
Please.
He's expert of the epilepsy surgeon, very famous, worldwide, the famous neurosurgeon from India. Please.
My screen and is visible, and you can hear my
visible.
voice.
Yes.
Yes.
Yeah. Okay. So good morning to all of you. Thanks to Professor Yako Kato as well as the leadership of the ACNS for giving me this opportunity for sharing a few thoughts on the epilepsy surgery concepts to the younger members of the ACNS. I have no financial disclosures in this presentation. Few images I have taken from the public domain for the demonstration purpose. So I'll be speaking on a few issues like neurogenesis, learning and memory, epileptogenesis, and bring up concepts in the understanding of hippocampal sclerosis as well as focal cortical dysplasia. So 37 trillion number. So 37 trillion, the number of cells all of us have in our body. So these cells are born, they grow, they perform their functions, and if there is a injury, infection, or any damage because of oncological process, these cells repair themselves and then eventually give rise to new cells. Unfortunately, such a thing will not happen as far as the brain and spinal cord are concerned, the neural system. For coming with this neuron doctrine, Raymond Cahal, almost 100 years ago, got a Nobel Prize saying that no new cells are born in the brain and spinal cord. Of course, the science scientific development subsequently proved that birth of new neurons, in fact, happens in the nervous system. So at birth, we are all endowed with 86 billion neurons, and predominant number of these neurons, 69 billion neurons, are only in the human cerebellum. So only 17 billion are in the entire rest of the brain. New birth of new cells, in fact, happens in three anatomical reasons. One is in the periventricular zone, where originally neurons are born, and second, along the olfactory tract, olfactory nerves. And the third and most important part of neurogenesis, birth of new neurons, happens in the hippocampus. So I'll speak more about hippocampus rather than the periventricular and olfactory areas. So Joseph Klingler is is a professor of anatomy who in fact taught anatomy to Gazi Yasargil. And Professor Klingler mentioned that in the entire universe of all the nature, the most complex structure in the entire nature is human hippocampus. See, it's a 4 to 5 centimeter structure on either side of cerebral peduncles, and it has got head, body, and a tail, and which has got about close to 1.5 billion neurons are there in the human hippocampus. So one of the predominant functions of hippocampus is consolidation of memory. All the short-term memory, which is usually located in the frontal lobes, goes through hippocampus for conversion, analysis, and conversion of short-term memory into long-term memory in the respective cortical areas subsequently. So to do this memory consolidation, the information has to go through hippocampus number of times. So hippocampus has got reverberating circuits. So the same information, same phone number, same face of a person, same data has to go through hippocampus number of times. So it has got reverberating circuits. Unfortunately, these reverberating circuits also lead to epilepsy, which becomes drug-resistant epilepsy over a period of time for a number of reasons. For example, the young immature hippocampus in children, newborn and children, is vulnerable to febrile seizures, to meningitis, to encephalitis, to head injury, and then eventually, subsequently, over a period of 10 years, 15 years, loses neurons, and then there's a glial cell proliferation, and then they will develop abnormal neuronal network, converting a normal immature hippocampus to an epileptic hippocampus. Fortunately, due to the advances in understanding epilepsy, in understanding drug-resistant epilepsy, and also application of computational techniques in neurosciences, like capturing simultaneous video of the human behavior as well as electrical activity, and also because of the phenomenal progress in neuroimaging, especially MRI, and also understanding substrates like mesial temporal sclerosis. Now we are able to identify people who are potential surgical candidates. And now there are randomized control trials suggesting superior efficacy of surgical interventions compared to continued medical management among the people with the chronic drug-resistant epilepsy. To give an illustration, I will present a few cases. This is a young lady who had uncontrolled drug-resistant epilepsy. This is a snapshot. You see, if you look at the her clinical features, she has got posturing of the right upper limb, with head turned to the left side. This is a very robust sign that Caesar has propagated from left mesial temporal to left basal ganglia. Amygdala merges with globus pallidus. So because of propagation, the Caesar propagation from left mesial temporal amygdala to globus pallidus and left basal ganglia, right upper limb has gone into tonic posturing. This is a very robust sign. And if you look at her imaging, there is a left hippocampal volume loss as well as hyperintense signal, and both interictal as well as ictal activity is suggestive of seizures coming from the left mesial temporal area. So this is the surgery. So this is the left sylvian fissure, and this is the left hippocampus, and this is the amygdala, which is the nucleus, anterior and superior part of the uh, temporal horn. So amygdala is a nucleus. It's being resected en masse along the anterior and superior part of the left temporal horn. The floor is by the hippocampus, and the roof is by the amygdala. Now, choroidal fissure is being opened. Choroidal fissure is the natural entry point of anterochoroidal artery to the temporal horn to supply the choroid plexus. This is the fimbria of the fornix. The fimbria of the fornix is being lifted up, and this is the head of the hippocampus. This is the body of the hippocampus, and the head of the hippocampus is being lifted, and in that space you will find the brainstem, the cerebral peduncle. Now, the hippocampal sulcus is one of the most important landmarks in hippocampal resection. See the hippocampus, and this is the fimbria of the fornix, and just below the fimbria of fornix, this is the dentate gyrus. And when dentate gyrus is lifted up, you will find hippocampal sulcus, where blood supply to hippocampus comes from the posterior cerebral artery branches. All those vessels have to be, we have to identify, coagulate, cut, and then only we can resect the hippocampus. Otherwise, posterior cerebral artery can be injured and can go into spasm. So hippocampus, and other side is the other side of the hippocampal sulcus is the parahippocampal gyrus that is being lifted from the floor. Once the hippocampus is dissected, head, body, and up to the tail, it's being removed en masse. Please don't use CUSA to fragment the tissue, because it becomes very difficult for pathologists to have a diagnosis, and you always attempt to do en bloc resection, so that the histological confirmation of hippocampal sclerosis can be obtained by the pathologist. So this is a en bloc resection of the hippocampus, and of course the remaining tail can be resected using CUSA, and same way uncus and the remaining part of the hippocampus, remaining part of the amygdala can be resected. Uncal herniation is a rule in all the cases of mesial temporal sclerosis. This is an observation by Ghazi Yasargil, so suggesting that all the people herniated during birth and early childhood, and then the survivors subsequently developed hippocampal sclerosis. This is the resection cavity, posterior cerebral artery, cerebral peduncle, and this is the anterochoroidal artery. Now, unfortunately, this sort of confined lesion and focus in the mesial temporal area cannot be obtained in extra hippocampal neocortical epilepsy. I'll give you a few more examples of this entity called malformations of cortical development, and in few minutes I'll conclude my presentation. So all the neurons are born in the periventricular area, and then they move to the cortical mantle. This is a time lapse photography. In 72 hours from periventricular area, there is a neuronal migration to the cortical mantle. This orderly process of neurogenesis and migration and then organization of the cortex can get impaired due to genetic predisposition as well as in vitro insults, leading to a number of malformations of cortical development. The predominant among these malformations is an entity called focal cortical dysplasia. Here you see there's a 4 millimeter cortex and then white matter. Whereas adjacent here, you see there's a thick cortex, very poor gray white demarcation, and which has got a dysmorphic and bizarre looking neurons. And this can happen anywhere in the brain. I'll just give you a few illustrative cases. This is a young girl who presented with frontal lobe epilepsy, and you see here the ictal onset is in the frontal lobe, and in the right frontal area there is a large hyperintense signal. So this is the abnormal area in the basic frontal area, and she underwent gross total resection of the anatomical abnormality. This is a young man with temporal lobe epilepsy. You see there is a large temporal malformation, and he underwent gross total resection. This came as a combination of periventricular nodular heterotopia and polymicrogyria. This is a young child who presented with regression epilepsy. This is a complex DNA which underwent gross total resection. This is a young lady who presented with regression epilepsy. There is a ganglioglioma extending from cortex all the way up to the ventricle who underwent gross total resection. So many of these people with chronic drug-resistant epilepsy, they're amenable for complete cure of their epilepsy with meticulous pre-surgical evaluation as well as surgical resection. I hope the young members of the ACNS will develop interest in epilepsy surgery and help hundreds and thousands of these deserving patients. And thank you very much for your attention. Thank you.
So thanks very much, Rao. So maybe I would ask Horisa Sensei to make some comment or question. Either Horisa Sensei. So maybe Dr. Skitch or Dilshot.
Thank you so much. Good afternoon, everyone. Professor Kato and Rao.
Dilshot, maybe you can identify, please.
Do you hear me?
Yes, yes. Please
Okay.
identify yourself.
Please introduce yourself.
Yes. I'm Dilshot Mamad Aliyev. I'm a neurosurgeon from Uzbekistan. I'm a current secretary of Uzbekistan Association of Neurosurgeons. And I am glad to be part of this interesting webinar series, which is being held by many distinguished faculty in this list of the ACNS members. And I'm very interested in the topic you just delivered for us. For young neurosurgeons, this lecture is very beneficial. And I have a question about the origin of the hippocampal sclerosis, which is postulated by Professor Yashargil. That is that what postulated hypothesis, or it's proven fact that the herniation during birth. In adults, they develop this hippocampal sclerosis, or this is only a theoretical point of view of Professor Yaşargil?
So this is a known phenomena. Actually, Professor Wilder Penfield named it as a insusural sclerosis. It is the tentorial insusura where the herniation happens. And subsequently, at the Maudsley Hospital, Murray Faulkner did en bloc resection, again documented all these features. The only the contribution of Ghazi Yasargil is that unlike his predecessors, he operated under microscope. And in microscope, he noticed in almost all the cases, there is some amount of herniation, uncle herniation. And in fact, during some of the surgeries were performed even during Penfield's time under local anesthesia. And when the uncus, herniated uncus was being removed, people developed respiratory arrest. Of course, nowadays, since we do surgery under general anesthesia, we don't notice this finding much. But Yasargil, because of his observation under microscope, made it prominent that uncal herniation is a role in all these cases. This herniation is different compared to the herniations we see with the tumors. We see the like a remnants of old previous herniations during childhood, lot of additions. So if during resection of this part, one has to take one's own time, do arachnoid dissection very slowly and carefully. If there are episodes of bradycardia, just wait for patient brain to recover. Dissect arachnoid slowly, gradually, release all the additions, and then you can take out the hippocampus and uncus. Also, some people do in piecemeal also for the same reason. So it is, see, for example, selective hemiglohippocampectomy is a procedure developed by Niemeyer in Brazil in 1950s. Yasargil popularized it. Same way, insusural sclerosis, herniation of the uncus, is an observation made earlier, which became very popular with Yasargil's contribution of selective hemiglohippocampectomy. He has highlighted it, just like highlighting use of microscope during the surgeries. Thank you.
Thanks so much. Thanks. So according to the schedule, maybe I move to the next one. Otani Sensei, Naoki Otani Sensei. He's from Nippon University, Tokyo, Japan. He is going to talk about some technical points about the microvascular decompression. And he will be the secretary of the Japanese Emergency Congress in February, very soon. Otani Sensei, dozo.
Prof. Otani, can you hear us?
I think.
Yes.
Okay.
Yeah.
Sorry. Can you hear me?
Yes.
Sorry. So it's a connected, so machine trouble. So I'm very sorry for connecting, delaying for the connection. So
Seems Prof. Otani got disconnected.
Okay, so maybe we move to the Horisa
Yeah, he's
Sensei.
here. He is here. Prof. Otani, can you hear me? Otani Sensei.
Maybe after Horisa Sensei.
Yeah,
So Horisa
sure.
Sensei, are you ready? Thank you very much for your contribution to the ACNS webinar many times. He is from the Tokyo Women's Medical University. He is expert in functional neuroscience, traits, movement disorders. Please.
Thank you, Professor Kato. It's great honor to be here. And sorry, my slides. It's okay. Okay, so my topic is force field surgery for movement disorders and beyond. So the force field is very unfamiliar to a majority of neurosurgeons, and actually, this kind of the surgery is rarely performed worldwide. But this target is very, very interesting, and I strongly believe that in the recent 10 years, this target will become more familiar and used for many, many kind of indications. And August and forest field. What is the forest field? The forest is from August Anneforel, who is a Swiss neuroanatomist. And the forest field is a subthalamic and tegmental region and in human, and named by the August Anneforel, for H field. And the H standing for the German word Hauben, so which refers to the nightcap aspect of this region. So it's like a cap. And the anatomically, the forest field, this is a coronal section. And if you look at this is a GPI, this is the major output structure of the basal ganglia. And the two fibers originate from the GPI and to the thalamus. And the two fibers merged at here, H, forest field H, and to form a single fiber. FT means thalamic fasciculus. And the fiber goes to the thalamic subnuclei. VL, so many kinds of thalamic subnuclei. So this fiber, I call it the pyrrhothalamic tract. And actually the field of Fourier, so many fibers passing through this area. But the major fibers is a pyrrhothalamic tract. So you can see the right figure also showing the coronal section of the basal ganglia and the thalamus. And the two fibers originate from the GPI and merge at for H and go into the VO or so many, mainly for motor nuclei. So the forest field H or H1, this kind of a field nearly equal the pyrrhothalamic tract. And the 1960s and 1970s, this is very interesting. So the three different neurosurgeons used this forest field H-TOMI for three different indications. The Spiegel and Weiss use this target for Parkinson's disease. And Lord Hasler used this target for cervical dystonia, and the Denosuke Jina used this target for epilepsy. And in 1960s or 1970s, the Spiegel and Weiss used this Fourier H aberration. They called it campotomy, campus Fourier aberration, campotomy for the Parkinson's disease, tremor, and rigidity. And actually, the symptoms strikingly improved after the campotomy. But at the same time, with the advent of a ventrolateral thalamotomy, now we call it the VIM thalamotomy for Parkinson's disease, reported at the same time by the Lord Hasler. And the VIM thalamotomy for tremor is really, really striking. And with the advent of a VIM thalamotomy, this procedure completely abandoned by Spiegel and Weiss. They moved to the VL thalamotomy for Parkinson's disease treatment. But 2005, Dr. Daniel John Monod, this is a Swiss neurosurgeon, revived the Spiegel's campotomy, Spiegel's Fourier H-TOMI for Parkinson's disease by using a radiofrequency aberration or focused ultrasound surgery. So the right figure showing the total UPDRS3 score, this is a subjective evaluating scales for motor symptoms in Parkinson's disease. And before and after the surgery, the score significantly improved from baseline to the 1 year. The lower the better this score. So the 1 year, about 40 to 50% of the improvement of the UPDRS +3 score. And then now cervical dystonia, this originates from Rodolph Hassler. The cervical dystonia is a neck movement disorders, and this is the pathophysiology of cervical dystonia by the Rodolph Hassler. This is the actual hypothesis, Rodolph Hassler's hypothesis. In normal state, the basal ganglia output to the neck so equally effective, but in cervical dystonia, the rotational torticollis. So he considered asymmetrical paradigm output plays a very important role in the pathogenesis of a cervical dystonia, and the abnormal side, ipsilateral side, to the aberration of the paradigm or forever H1 area in the abnormal state may be a key structure to control and to improve the cervical dystonia symptoms. And actually, he ablated the region at the forever H1 in the contralateral side to the head direction. And this figure is a Hassler's patient before and after. The completely her neck symptoms completely improved after 6 months after the surgery. But this is also this was also abandoned in 1980 to 1990s. Probably with the advent of a deep brain stimulation on the globus pallidus internus. Now this is a widely is completely established surgical treatment for cervical dystonia. And we reported 2 years ago the unilateral forehead H1 Tommy for the cervical dystonia. So in our case, provided a 46.4% improvement of a subjective objective evaluating scale for cervical dystonia, Twisters scale. And now the bilateral GPI DBS is established, a worldwide available surgical procedure for cervical dystonia can provide 50 to 60% improvement of Twisters scale. But this procedure doesn't require the device implantation into the body and have only unilateral procedure. So considering this surgical procedure, so 46.4% improvement, this is I think this is a very nice result after the unilateral regioning surgery. So this case this is a left side torticollis. He had a right side procedure. So he had retrocollis with a left hand dyskinetic movement. So he had a right side surgery. But just after the surgery, the patients could achieve the significant benefits of dystonic symptoms. So we compare the results between the palidotomy GPI region. This is the most available target for cervical dystonia, and the forehead H-tomy, and 47 or 46. So the results between these two targets are completely same. So we can treat the cervical dystonia by using this forehead H1 forehead H area to target. And now we finished the clinical trial. This is actually our world's first clinical trial of a focused ultrasound surgery for cervical dystonia. The target was the forehead H1 area. The focused ultrasound is a cutting-edge technology which can make ablated lesion in the deep-seated structures without the skin incision, without penetration of the electrodes into the brain, by using a focused ultrasound. And we can monitor the thermal region by the MRI thermometry. So this is cutting-edge functional neurosurgical technology. So this is our first case of a cervical dystonia treated by the focused ultrasound. So the head shaking and the slightly right side torticollis she had, and left side forehead H1 aberration by focused ultrasound, just above the subthalamic nucleus and just below the thalamus. So this is a 1 week after the procedure. The conditions little bit better than before, but still shaking. But her symptoms gradually improved with time for 6 months. Actually, this clinical trial, the follow-up period was 6 months follow-up. So 1 month. So already she had almost nothing of a head shaking movements. And 3 months after, a little bit shaking, but she was very, very happy to have this surgery only after unilateral for H1 ablation with focused ultrasound. So actually, she didn't require the deep brain stimulation device implantation surgery. So this is another patient of a clinical trial patient. So cervical neck lateral cord is the left side. So with the left side shoulder elevation. So like this was relatively severe cervical dystonia symptoms. And this is a focused ultrasound procedure. So we've ablated the forward H1 area by focused ultrasound, which achieved a 55 or 56 degrees on the target, which is a necessary temperature for a necrotic region. So this is just after the surgery, the shoulder elevation greatly improved right after the focused ultrasound. And 1 month surgery, the neck torch cord, lateral cord is slightly improved. So it's much better than before. So this is also an alternative treatment target for cervical dystonia, not GPI and for H1 Tommy. And additionally, I want to emphasize this single case of this is a Huntington's disease, Huntington's chorea. All of the neurologists consider this is out of the surgical indication, but actually that is not correct. So this is a very serious correct movement on the 4 bilateral upper and lower extremities and whole bodies. So very serious correct movements. And she could stay as a rest condition. This is 6 months after only after the unilateral left side forward H1 aberration, and her correct movements dramatically improved. And before the surgery, for 2 years, she was on the completely wheelchair bound. But after the procedure, she began to walk independently. So the chorea is one of the best indication of the functional neurosurgery. So Moyameya's disease associated chorea or Huntington's chorea or chorea acanthocytosis. So any kinds of chorea is a very good indication of the stereotactic neurosurgery. So the epilepsy is an additional indication of this procedure. So this is a Japanese neurosurgeon, Denosuke Jinei. He used this target for epilepsy treatment in mainly 1960s and 1970s. So today we don't have much time to talk about detail about this procedure for epilepsy, but it's very roughly, I can say that the putative mechanism of Fourier H-Tommy for epilepsy is one of the interruption of seizure conductive pathway by the lesion. And also the lesion can elevate the seizure threshold. So these two putative mechanisms are considered as why this procedure can improve or reduce the seizure frequency or seizure alleviation. And we experienced a very interesting 2 cases for the patients with the movement disorders and epilepsy. And we already experienced so many patients with movement disorders by the surgery on Ford's field. And this patient had a movement disorder with epilepsy. If you look at this area, left side temporal lobe glioma, epilepsy, and she had a focal impedance awareness seizure once every 3 months, and order 5 to 20 times daily, and with 4 anti-seizure medications. And she had a Fourier H-Tommy for the treatment of movement disorders. But finally, she experienced the great improvement of the seizures. Actually, the order reduced to less than 10 times a year. And now she had nothing of focal impedance awareness seizure. So the completely seizure free for 1 year. So then the second case also a great improvement of general tonic-clonic seizure after the Fourier H-tomy, but he also had a head dyskinetic movement. So the surgery was intended to treat the movement disorders. But we noticed that this procedure may be a good option for epilepsy. So we started and also finished the small clinical trial of Fourier H-tomy for epilepsy. This is a second case of a clinical trial. She was post-traumatic epilepsy with a focal impedance awareness seizure once every 3 months with 4 kinds of anti-seizure medications. So she had a very wide damaged brain, so relatively difficult to introduce the electrode to the pyrothalamic tract at the field for rail. So this is a surgical planning of this patient through the parietal lobe, the very small, tiny lesion. And she was seizure-free for now 2 years. So, and this is the third case of a clinical trial, post-stroke epilepsy on the left side parietal lobe stroke. He had a focal seizure 3 times in a week with 2 kinds of medications. And he had a very small, tiny lesion in the Fourier H area. And he also had a seizure. He was also a seizure-free for 1 year. So this treatment must be a good option for epilepsy, but still we are not sure whose candidate is the best for the Fourier H-tomy. So we had so much patients to confirm the good candidate. So lastly, this patient, I want to introduce this patient. This patient had a cervical dystonia with obsessive compulsive disorder, which is a major psychiatric disorders. And she had the Fourier H1 region for cervical dystonia. And of course, the cervical dystonia greatly improved after this procedure, but simultaneously, her psychiatric disorders, obsessive compulsive disorders, very much improved after this procedure. So the anxiety also a little bit improved. So her obsessive compulsive disorders, the major symptoms were cleaning compulsions. So before the surgery, hand washing 20 to 30 times a day, and after the surgery, less than 10 times. So bath time also greatly reduced from 2 to 3 hours before the surgery to less than 1 hour. And she also had an auditory hallucination 3 times a day, which reduced to the 1 times in a month. So this is a very interesting story. And why these different indications improved after this procedure? This is our speculation. So we had basal ganglia cortical circuits whose have 3 different functions. One is sensory motor, and the second is associated, third is limbic. The other movement disorders surgery targeted on the circuit of the sensory motor basal ganglia circuit. And these three circuits project to the different regions at the cortex or basal ganglia and the thalamus. But look at the FF, this is a 4-rays field. So only at this point, 3 different segregated pathways merged at here. So that's why the ablation or stimulation at this single point simultaneously may have impacts on the sensory motor or associative circuits with which is associated with psychiatric symptoms or limbic symptoms. So these 3 circuits we can stimulate or ablate simultaneously. So that's why this region, this place, this site is a very, very interesting for many kinds of indications. So now we have several treatment surgical options: radiofrequency ablation, focused ultrasound, or gamma knife for deep brain stimulation. So these procedures are available for promising indications, including movement disorders or epilepsy or psychiatric disorders. Okay, thank you. Thank you so much for your attention.
Mr. Sensei, thank you so much. So maybe Dr. Rao, so you have some question or comment? please.
Very, very interesting presentation with dramatic recovery. My question is regarding focused ultrasound. If there is some problem with the DBS, deep brain stimulator, you can stop. But when you created a lesion with focused ultrasound, this focused ultrasound is purely based on anatomical localization. If there are errors, the lesions are irreversible. There is going to be damage. So what precautions young people can take to prevent permanent irreversible damage because of the lesions?
So by using a focus ultrasound case,
Yeah.
okay, so yes, so actually the focus ultrasound, we always firstly provide test sonications, very lower power focus ultrasound, which increase the temperature about 45 degrees, less than 50 degrees, which is a reversible region. And we carefully confirm the side effects after the test sonications, so less than 50 degrees sonication. And if the patient doesn't have any side effects after the sonications, we again the shot on the treated sonications, which is higher power sonications, which the food temperatures at least 55 degrees. So that the careful observation after the test sonication is I think the most important to avoid the serious irreversible complication in the focused ultrasound surgery. Okay.
Thank you. My concern is that many centers may not report their early complications, so bit concerned. Thank you.
Yeah.
Anyway,
Thanks so much.
Yeah.
thank you.
Okay, the shots. Do you have a question?
Yes, thank you so much, Horisawa Sensei. Very interesting lecture. My question is, you told that this pallidotalamic tractotomy is very useful in many cases of chorea. Is the same region is distracted during this procedure for every type of chorea? Dyskinesias, or there is a specific nuances that should be taken only Forel's field in every case of chorea, or there is any differences?
Okay, so the chorea is obviously associated with a basal ganglion cortical dysfunction. So the chorea is, so actually the pallidotomy, so GPI pallidotomy is the Huntington's chorea is the first indication of a pallidotomy for movement disorders. I think 1960s, 1970s. This is the first indication of the pallidotomy, but I'm not sure that at this time, from now, only 4 cases with Huntington's chorea are reported, treated by the pallidotomy. But the chorea acanthocytosis, other types of the chorea, chorea acanthocytosis is frequently treated by the GPI DBS, bilateral GPI DBS. And the effects was really, really nice. I think the more than 19% improvement of chorea. And in case of chorea acanthocytosis. So I think that any kinds of the chorea share the same circuit dysfunction. So the aberration or intervention on the GPI or intervention on the pallidotomy tract of Fourier field H, it is about GPI and the Fourier H belongs to the same circuit. So the possible improvements, I think the same. So in dyskinesia or chorea or Huntington's chorea, I think that any kinds of the chorea is a good indication of this kind of surgery.
Very good. Thank you so
大丈夫
much.
ですか？はい。Thank you so much. では、吉田先生、ありがとうございました。
あ
So
り
we
がとう
move
ござい
to
ました。
back to the Odani sensei. Odani sensei, ready?
Yeah. Okay. Sorry for the internet condition is so unstable. So there's no time. So I will show you my talk. Today I would like to talk about the microvascular decompression. So I will share my slide. So can you see
Yes.
the slide? Just a moment, please. Okay, can you see?
Yeah.
Sensei, yeah, we can see.
Okay, yeah. So you see the bird rhyme techniques. So bird rhyme mean the in Japanese naming torimochi to catch catch a bird like this. So we usually use transposition, vessel transposition technique using these adhesive material. So I will show our techniques, and I will introduce my techniques. So in microvascular decompression, so there are mainly two methods, transposition and interposition, which inserted the material between the nerve and vessels. So many reports have suggested that the transposition will be more effective, less complication, even if you think about it logically. As you see in this slide, there are so many transposition techniques. So snare technique, which reported in 2012, and EPT membrane, and the dual sling techniques, and fenestrate clip was used. Well, anyway, these techniques will be needed, suturing technique in deep operative field. So on the other hand, the vessel transposition can be performed using adhesive materials. In 2004, Dr. Kurokawa have reported that just only using the fibrin glue, and in 2011, Ichikawa reported the use of the taco kombu with fibrin glue to fix the vertebral artery to the petrosal surface. So which namely the double stick tape techniques. So in 2008, I summarized this reported. So as the same way, using the taco shell to make the adhesive material with fibrin glue. This product has an active yellow side coated with the human thrombin and fibrinogen, and a supportive white side coated with collagen. So taco seal, this tissue sealing sheet is ready to use a surgical patch that consists of the white collagen sponge coated with the side and fibrinogen and thrombin. So we modified this technique so as to improve the handling and performing this material, which is easily trimmed with finger and soaked with fibrin glue, and to create adhesive material similar to the bird lime, as shown in the previous slide. So I will show the schematic illustration of the microvascular decompression for trigeminal neuralgia. On another way, you see the Teflon felt. You see the SCA was dissected and put the taco shell on the tensory surface and adhesive. So and on another way, you see the Teflon felt was wrapped around the offending artery to lift it up and secure it to the tentorial surface. So after all adjustment was completed, the adhesive site was additionally secured with additionally fibrin glue. So we have checked, comparison only compares the adhesive strength between the fibrin glue only and the Teflon felt and the fibrin glue and the taco seal. So as you see in this slide, the taco seal with fibrin glue have proven to have the strongest adhesion, significantly. So I will show the several cases. So this case is 62 men presented with 3 years history of left-sided facial spasm. So preoperative MRI shows that tortuous left vertebral artery identified in the pontomedullary junction as indicated with the black arrows. So the left pica also compress the proximal portion of the facial nerve at the root exit zone. So so I will show the operative video. So so underwent the transcondylar fossa approach to gain the wide exposure of the root exit zone of the facial nerve. You see that this is here around here is a root exit zone. So offending vessel, the vertebral artery was put and to Petrosa's site, and you see that. So vertebral artery was lifted up, and additionally, taco seal was adhered like this, and you see the meticulous fixation was completed, and the addition the pica was fixed with vertebral artery. So finally, you see the finally, ICG angiography was performed to confirm the patency of the vessel and perforators, and the postoperative course was uneventful on this case. So you see the postoperative MRI that shows the vertebral artery and the pica was completely transposed from the root exit zone. So you see the taco seal was was confirmed like this. You see. So this case is a left hemifacial and concomitant with a glossopharyngeal nerve neuralgia. So you see, as the same way, the offending vertebral artery was fixed and adhered to the petroleum surface with the borderline material, and so this is a left vertebral artery. So you see the fixed with using the taco seal material. And additionally, the Teflon felt was inserted between the glossopharyngeal nerve and the vertebral artery. And in addition, the pica was transpositioned to the vertebral artery. So like this. And the post-operative course was uneventful and the symptom was freely. So next case, so is a 59 man suffered 5 months duration of the left trigeminal neuralgia and 1 month is of involuntary spasm of the left side hemifacial spasm. So you see the MRI, preoperative MRI reveals the significantly dilated and tartarus, the vertebral vaginal artery, which was connecting the left trigeminal root entry zone and the facial nerve as indicated as yellow or arrows. So left vertebral angiogram demonstrated the tartarus course of the vertebral arteries. So this procedure performed using the lateral sigmoid approach. So the dolichoectagic vertebral artery compressed the trigeminal root exit zone along the lateral side of the trigeminal nerve, and its nerve complex. And the vertebral artery was so hard and immobilized that it was very difficult to decompress the nerve in the usual manners. So therefore, we usually we use the taco seal to so detach from the nerve, and you see the here's a trigeminal nerve, and this is the here is the root exit zone of the seventh nerves. And so immediately after surgery, the symptoms have completely disappeared. And there were no post-operative complications such as hearing loss and facial paralysis. And the patient was working independently within 2 weeks. And the last cases, this case suffered left-sided pulsatile tinnitus and progressed for past 6 years, and vertigo had been accompanied by since 3 years ago. So you see the MRI shows that the ICA forms a loop and compressed the auditory vestibular nerve within the internal auditory canal. So oral carbamazepine was effective. Therefore, the ICA seems to be the offending artery of the neurovascular compression. So we have decided to decompress microvascular decompression. You see the drilling with open the internal auditory canal, and so the decompressed ICA using the Badline techniques. So this case I have post-operative course at and eventful, and the symptom was completely free. So I summarize the advantage of this method. So you see this material, Badline material, and strong adhesion and soft and well handling and flexibility. And so as I see you in this slide, MRI image, we can track the evaluation of the effective of the microvascular decompression. And I will show the safety of this material. Tacocomb, it's a bovine thrombin fraction. So there is a BSE problem, but now the taco shield has a human thrombin fraction. There's no BSE problem. And this taco seal was approved for use in dural closure in Europe. And intradural use, the Helsinki team has reported this material is very safety in intradural using. And granulation formation and the long-term result as unknown. So in my cases, about around 9% and has showed a transient delayed facial palsy, but the cause was seemed to be the chemical meningitis, and so around 1 month or 2 months, so the symptom was completely improved. So you see and recently we summarized the long-term result. You see, so totally around 60 patients, hemifacial spasm and trigeminal neuralgia, and the effectivity is like this. So I will show so no abnormalities, including a mass that suggested granuloma formation. So I think the taco seal is not so not so risky, and otherwise safe and precise and easy techniques for the microvascular decompression. So in conclusion, I summarize this slide. Thank you so much.
Thank you very much, Otai Sensei. It was wonderful and very informative presentation with Takocom.
Prof. Ibrahim is here.
Professor Ibrahim, do you have any question? Ibrahim? So please, Rao.
Two questions. Two questions. One is this Tacosil. Is it biodegradable? How long it will take to degrade? Will it take weeks, months? How long it will take to degrade fully? It's a biological product.
Just
Dr. Otani,
Yeah.
the Tacosil
Yeah.
cannot be there forever. It will degrade with time. It's a biodegradable material. It breaks down with time. Can you hear me?
Yeah.
Okay, I have two questions.
Sorry.
I have two questions.
So guideline material use the tacosil same as glue fibrin. Yes. Yes, it's a fibrin glue.
Yeah, please go ahead.
Yeah. So Dr. Harrit, thank you for your question. So this it doesn't increase the cost a bit. Yeah. About one. So it's a. In the, not so cost effective. Not so the cost. You understand?
Yeah, I have another question.
Yeah.
Do you plan everything on the table during surgery, or you do simulation before surgery and then plan what to do?
Yeah. I usually post-operatively perform the 3D FLAIR MRI and 3D CT angiography. So we usually make the 3D images to perform the you see
that's done before surgery, pre-operative.
Yes, yeah,
Okay.
pre-operatively. Yeah. I
Oh.
usually make the fusion images with MRI and 3D CT angiography.
Okay, thank you.
Shot, please. Your shot.
Yes.
Yeah.
Horisawa Sensei, Otani Sensei, sorry. A nice presentation. Have a question. So, do you use this bird-lime technique selectively for cases in which offending vessel is large vessels like vertebral artery, basilar artery, or you can use it for in every case like a simple SCA compression or other cases?
Thank you for your good question. To tell the truth, I usually use in all cases to use tacosil because it's very easy and adhesive strength is so tough, and I think it's so very safety techniques. So as you indicated, of course, so main trunks, the vertebral artery or the basilar artery, it's very effective for the safe and precise microvascular decompression for these cases. But I always I use all cases for the microvascular decompression.
Thank you so much.
Abe Sensei, どうぞ。
Good morning. Thank you, Otani Sensei, for the nice presentation. Very interesting, really very interesting. In my experience, I usually decide what to do intraoperatively. So if the anatomy is favorable, I try to sling the vessel to the dura with a suture stitch. So if it is not so easy, then I select the interposition technique between the nerve and the vessel. So my question is, do you use this technique always as a first choice, or you use also other techniques depending on the anatomy?
Yeah, thank you. Thank you for your good question. It's similar the previous question, but I always use in all cases taco shell. So so basically you use the taco shell, and so for the this so this technique is effective for the transposition of for the vein. Petrosal vein transposition technique is very easy and not so risky techniques for the venous transposition. It's very good. So and as Dr. Bari questioned, so vertebral artery and basilar artery is very easy transposition this using these techniques. So so Ferretti, Dr. Ferretti, of course, so questioned about these techniques for the so case by cases. As Ferretti mentioned, so case by cases, we should so select the so surgical techniques. So using the taco shell or the only sling techniques, or the so interposition, just only interposition. But mainly, I usually decide to use taco shell in all cases. And of course, we transposition and interposition concomitant method. We usually sometimes the additionally so perform the insert the Teflon felt. You see Teflon felt.
Yes.
Yes.
Yeah, very
combined. Combined.
Combined techniques. Yeah.
Combined techniques. Yeah.
Arigato.
どうも。
Prof. Kato, you are muted. Can you unmute your mic?
Thank you very much, Otani Sensei. Dr. Arbel, we'll see you soon in Tokyo, I think. Thank you very much.
Yes,
So
yes.
now we move to the next speaker, the Professor Raja. Of course, everybody knows because he is one of the board member, and already he conducted more than 300, nearly 400. I don't know, maybe Professor Raja he said. Today he will talk about the transamic and acid in the management of the chronic salivary hemorrhage. Because chronic salivary hemorrhage, everybody has a lot of concern. So we are expecting your lecture, please.
Well, at the onset, let me thank Prof. Kato and Prof. Ibrahim for giving me this opportunity. This has been a wonderful association between the Bosnia Herzegovina Society as well as the ACNS. So I'll start my presentation today. This is a very interesting study that we did, and also I'll talk about the rest of the things. Okay, I hope you can see me. So this is a very novel study that we had so far, the largest series in the world as of now, and thanks once again for inviting me and giving me this opportunity to present. So I come from Kerala. This is the southernmost part of India, also known as the God's own country for this beautiful landscape and lush green ports and sceneries. This is my hospital. I work in Government Medical College Trivandrum, the first and the largest hospital in Kerala, nearly 4,000 bedded hospital. So we'll talk about chronic subdural hematoma. So as once remarked by Prof. Harvey Cushing that there is nothing in the whole realm of surgery more gratifying than the successful removal of a meningioma, and with subsequent perfect functional recovery holds good for most cases of chronic subdural hematoma as well. So there was a survey in Austria, German and Swiss neurosurgical units, and they had a question that is watchful waiting a viable option in the treatment of mildly symptomatic chronic subdural hematomas, and there were 74 respondents, and most of them agreed that this is a worthwhile option. But there are many other options that we can do in while the patient is waiting. So we'll just see the options here. So they are steroids, statins, and the Gorisan drug, which is Japanese campo medicine. Then you have the ACNS inhibitors, and then of course tranexamic acid. So the recently published DEX-CSDS trial by Professor Peter Hutchison showed that there is a favorable outcome is less when you compare with the placebos, and also there are serious adverse events in a short term. And then after this study, the NIHR came out with the statement that it could be doing more harm than good, and it was they recommended that clinicians should stop prescribing dexamethasone to patients with chronic subdural hematoma. So, and another result from the same surveys whether they used chronic subdural steroids for CSDH or tranexamic, and people are more skeptical in using steroids. So, the first experience of tranexamic acid was by Vachkovic et al., and he had a patient who had he was a patient with CRF and who was on hemodialysis, and after 3 recurrence, they started him on tranexamic acid, and with a complete resolution at 4 weeks. And then followed by this came the largest series, which came in 2013 by Professor Kageyama et al. From Japan, and they had a 100% success rate. I was fortunate to meet Prof. Kageyama in 2019 when I attended the Japan stroke at Yokohama. And this was followed by the study by Omar Tanvir, who had given after SEPS, that is subdural endoscopic port evacuation for subdural hematoma from Medtronic, and they gave tranexamic acid after the removal of CSDH through SEPS, and they showed that tranexamic has an additional resolution of 91% in patients. So this is the very recently published study, and they have shown that this is a study from Japan, and there were around 7,000 people who used CSDH, and reoperation was slightly less in TXA users than controls, and there was no significant difference in composite adverse events. We published our study in 2020 in the Journal of Stroke and Cerebrovascular Diseases, and these are another which are tracks trials which is going on. You can find the similar trials going on the website. So our first experience was through this patient. This patient was a HIV positive patient, a female lady who came into my OPD. She was a history of assault, and we decided to do a twistal craniostomy in her, and we did. And halfway the twistal craniostomy, she developed seizures, and we had to stop it. So after the procedure was stopped, and she was then. She was very conscious, and she did not have any deficit except for headache. And then we started her on tranexamic acid, and you can see the resolution of symptoms, and we had a very good result. So this was the first index case that we had in our experience, and this was published in Journal of International Associate Providers for AIDS Care journal in 2017. So what is the mechanism of actions? For that, you must know about the pathogenesis of the CSDH, where there is an overlapping of osmotic grading inflammatory process as the recurrent hemorrhagic model with hyperfibrinolytic activity. And pathway starts with the breakdown of a hematoma into products, which sparks an inflammatory process, and then you have a clot, and it may expand and break down as an osmotic gradient is created, causing ingress of fluid into the hematoma. And there are neovascular membranes. So plasminogen plays a real critical role in the pathogenesis, and traumatic brain injury, as you all know, releases plasminogen activator, and this plasmin activates the fibrinolytic system and promotes the liquefaction of SDH and propagates the previous cycle. And plasmin simultaneously activates the kallikrein system, which induces inflammation and increases vascular permeability of the subdural hematomas. So what does TXA does? TXA is the small dots. You can see the bluer ones are on the TXA, green ones is the plasminogen, and the yellow is the TPA. So what it does is that it is a lysine analog which reversibly binds to plasminogen lysine receptor and thereby blocks the plasminogen from binding to fibrin. And that is a mechanism of action, and it breaks the cycle of membrane formation, rehemorrhage, inflammation, and increased vascular permeability, thus allowing resorption of clot over the time without expansion. So this was a prospective study. We enrolled from 2017 to 19. It was a SBMR funded study, and there were 27 patients with 30 CSDH, 14 males and 13 females, and 5 had bilateral CSDH. 2 underwent surgery for CSDH on one side, and the CSDH on the other side was enrolled in the TXA group. But also during the same time, we have operated 475 cases of CSDH that were operated by either burhole craniostomy or triple craniostomy. So the message is that chronic subdural is, of course, a surgical disease. This conservative management is reserved for very few. I have people calling me from all over the country as well as also from abroad. This is our first patient who wanted to shift to Trivandrum. He is from Toronto. The other one asked through emails from USA if you can throw some more light on your research. But I always said that you show it to your neurosurgeon and ask him for advice. So coming back to our study, the mean age was 63.9 years, and this is the Mark Walder grading. All of you know about it. So in our group, we had comorbid associations highlighted in the red, and also most common symptoms are headache followed by hemiparesis, and the volume was around 30 to the least, and the highest volume was 350 ml, and the number of days was 27 to 120 days, and thickness was 27 to this is the mean number of days treated, and the comparisons of volume before and after, you can see that final volume is very low, almost immeasurable. And this is the patients who were treated primarily, and this is with secondarily. Secondary is after surgery who had recurrence, and there is no complications related to treatment. So I'll show a few examples. This is a classical case whom we have. This forms the most of the bulk of the patients who have a CSDH either through scans for a routine headache, and we start them on TXA without surgery, and you can see very good resolution of the almost total resolution of CSDH. And second case very similar, bilateral CSDH after 4 weeks, and one side is resolved, and after 6 weeks you can see the total resolution on the opposite side. So I'll go to some more interesting cases. This is a patient, is a known case of lymphoma. He had a bilateral SCSDH, and we operated it on the left side, a single burr hole, you can see. And on follow-up, he had a recollection on the right side. Also, there is something on the left side also. So we again did a burr hole on the right side, and it rebled. And then we proceeded to a formal craniotomy, and you can see after craniotomy also there is bleeding. And again there was a bleeding, so we resorted to a decompressive craniectomy, and you can see, and surprisingly after DC also he had a recollection. This is very surprising that I have not seen a patient who develops chronic subdural hematoma after decompressive craniectomy. So we resorted to aspiration of the hematoma, and there was again a recollection. So now we are stuck. What should we do? So we started him on tranexamic acid, and you can see that as hematoma is slowly subsiding, almost resolving. And after 2 weeks, and after 4 weeks, it is almost gone. This patient lived for another 2 years before he died of his primary pathology. You can see total resolution after 6 weeks. This another example, which left-sided chronic subdural hematoma, and she was once operated, and again there was a recurrence, and she was started on Tranexa. You can see total resolution. And this is a very interesting case. This patient was actually in coma when we first saw him in the medical ICU. He was E2, V2, and almost M3, M2. So this patient, we advised surgery, but the bystanders were not at all willing for surgery. Surprisingly, he was ventilated, and after some mannitol and all, he became conscious. Surprisingly, so he was discharged from the medical side later after, and he walked into our OPD. And after 4 weeks, we see this is the status of chronic subdural, and we started him after 8 weeks of Tranexa. The subdural is totally gone. So he had a very good outcome. This another lady, 87-year-old lady with left hemiparesis, was not at all consenting for surgery. You can see total resolution of chronic subdural hematoma after 115 days of tranexamic acid. Another case, this patient, we thought it is some meningioma which has bled, but he was totally asymptomatic. So a young guy, 39 years old, only had some mild headache, no localizing lesions. So after 30 days of Tranexa, it is slowly, you can see resolution is happening, the change in density, and you can see there was actually an arachnoid cyst on the left side, which there was bleeding into it. So he had a very good resolution. This another female who was operated earlier and successful surgery before 1 year, but she had a very stormy post-op period, and hence she was not at all ready for a resurgery, and we gave her Tranexa. You can see total resolution. So conclusion, we had excellent outcome with all 27 cases, no complications so far. And the concerns regarding complications are theoretical and overstated. The main concern is, of course, DVT and seizures. And DVT, there are several trials which came up which showed that the risk is rather overrated, and also seizures is also, we had actually a letter to the editor saying that this treatment can be associated with seizures, and we I had replied to that letter, and the reply is that there are 3 doses of Tranexa as examined by Lin and Zoe et al. In the meta-analysis, and the lowest doses included in their study was 24 to 50. But what we give, and there was the incidence of seizures was very low at the low dose and high at the higher dose, and our dose was lower than the lowest dose examined. So there is no concern of seizures in or patients who are taking at such low doses. So limitation of the study, of course, there was not a control group, and without control group, it cannot be statistically proven that an intervention was successful. And also there is a fact that CSDH can resolve spontaneously without any intervention, adds to the dilemma. So however, most CSDH in Australia were relatively large and generally believed to be a surgical candidate by the surgeons in the peripheral hospital. So thank you very much for your patient listening.
Thank you very much, Dr. Raja Sensei. So it was very marvelous, the lectures through so many papers you read in the exam. So Kit?
Yeah, hi, Dr. Radha. Excellent lecture. I just want to know, what is that low dose of tranexamic acid? And do you taper the dose, or you keep the dose same?
No, we keep it same, 250 milligram TDS. That is the dose we give.
Okay, thank you.
Thanks. So Albert?
Congratulations, Raja, for the study and also for very impressive results. My question is, are there contraindication for the use of tranexamic acid, like, I don't know, blood coagulation problems, or you mentioned you used tranexamic acid sometimes in some patients after performing surgery. So do you have to wait for a certain period before giving these patients tranexamic acid? So what are the contraindications, if there are?
Well, there is a concern for DVT. Of course, I agree that recent literature has showed some evidence that this may be associated with the DVT. So what we did in study this, that before starting we had a routine screening for DVT in these patients, and also in older age patients. So I was really skeptical in starting tranexamic acid for that older lady, and she was not actually a part of this study, but she had we started her on in, and she routinely we had a Doppler study of the lower limbs once a month. That is the only concern regarding DVT. I don't think there is any other possibility, but I think we have my wife works in the cancer center, one of the highest volume centers, and in their experience of patients with the bleeding, they routinely use tranexamic acid. So there is like in coagulopathy in cancer patients, there is very high risk, but in clinical practice actually they have not seen it. So I think the risk is rather overstated, but to be on the safer side, it is better to have a baseline Doppler study of the lower limbs and screen them for once a month at least.
ありがとうございました。はい、大谷先生どうぞ。
Thank you, Dr. Raja, for your good presentation. So I am very surprised because Dr. Kageyama is my close colleagues and yes, so I know he is very, very interested in the tranexamic acid for the chronic subdural hematoma. So one question is, how do you think about the changes of the hematoma characters after the tranexamic acid administration? So because so tranexamic acid so sometimes induce calcification or other so not fluid correction. So
I understood.
Yes,
So
changes of the hematoma characters.
So the earliest sign that I have observed, I cannot say it like it is proven, but the earliest sign that we see is a change in density of the hematoma. So that is the one of the signs that I have observed, that it is like going to be successful in this patient. But I have not seen like calcification as you mentioned, but that it becomes more hypodense on CTs. That is what I have seen.
Yeah, thank you. Thank you so much.
どうも、ラジ先生ありがとうございました。Because we have so many daily surgery of the chronic subdural hematoma, very routine surgery. Even we don't know the cause. And also we have popular to use compo medicine, but still so many patients is coming back after the surgery. So but a very effective lecture. Thank you so much, Dr. Raja. Once again, thank you very much. So I think in between our lectures, I'd like to introduce the society president of the Professor Ibrahim, the president of the Bosnia Herzegovina country. Ibrahim, because maybe he will leave earlier, so I want to introduce now.
Hello.
Hello, how are you?
Thank you.
Thank you so much.
Good afternoon. How are you
Hi.
doing?
Fine,
Good to
thanks.
see you again. I'm
Yeah.
here. Actually, there's some troubles behind, so I have to solve it. I would like to say hello to all our guest speakers today. Very famous and nice big lectures we have here. I appreciate for contribution to all of you, especially the Professor Kato's team who help us to organize those meetings. And of course, I followed those webinars today, and next time I will give you a lecture also. So thank you. I'll be here for time, some 1 hour, and follow the lectures, and then I have to left the webinar. But my colleague Adi is here, and he will continue with leading.
Thank you so much for your greeting. And just I want to ask the Balkan Peninsula, so many countries you are reading. So I think what advancement or what is your how do you say the wish to more advance in your country? I think. Can you tell us, please?
About the Balkan countries, neurosurgery, development,
advancement, and also the wish.
There is in the region 10, we say 12 actually countries, including some new countries. Here, this is a population about the more than 100 million people, and there is approximately one neurosurgeon per 100,000 population. So we are trying to make centers of excellence in the region. So because there are so many small countries like the street in Japan, or for example, there are countries with 500,000 population. So there are small centers, and we are trying to organize the education in the region in the way that some centers treat some difficult cases, and in another places are centers for the another field in neurosurgery. So in our country, it's impossible to have cover all the field of neurosurgery in every center. So because of low population. However, we are trying with those webinars, and thank you for help us to develop the countries, to share the knowledge around, and to keep in touch with the evidence-based neurosurgery, which is now contemporary in the world, especially in the Western countries and Japan and region. So thank you for that.
Okay, thanks so much. Maybe Dr. Albert, he went to your country, so maybe in the near future we can have some collaboration, such kind of workshop, hands-on. So Albert, you want to say something?
Yeah, hello, Brahim. Good to see you.
Hey, Alberto, how are you doing?
I'm good, thank you. So actually, Professor Cato, you said that I went there to Sarajevo. It was a great experience. And we already have some collaborations. Some students from Sarajevo visited Italy, and Adi himself will be here soon this year. So there are already collaborations between University of Verona and University of Sarajevo and Brahim's department. So I think we need this kind of collaborations all over the world to improve every place, I think.
ありがとうございました、アルベルト先生。So, okay, so maybe I think we move to the next speaker from Bosnia and Herzegovina. Maybe Dr. Adi? Are you ready?
Yes, I'm here. I'm here. Maybe my connection is unstable. I'm not sure. Do you hear me?
Yes, I can hear your voice.
Okay. Then I will proceed with my lecture.
Yeah. Maybe you can say some greeting from your country, I think.
Yeah, of course. It's a great pleasure to be in front of such distinguished lecturers and professors. As far as all of you know, we are coming from Bosnia, which is a Balkan country. Sarajevo is a capital city, and this is the department where we are working together. Professor Ibrahim and me, we are in the same department. And as Professor has mentioned, that we are trying to establish the Center of Excellence here in Sarajevo, especially in terms of complicated cases as aneurysm surgery, cerebrovascular, skull-based cases, oncological cases, etc. So if you hear me, I hope you do. I'm in hospital right now. I can start with my lecture. Do you see this slide?
Yes.
Okay. So this is a lecture about actually endoscopic assisted aneurysm clipping, which is some kind that we started to do in a previous time. We don't have any disclosure, and we want to acknowledge to Professor Kato, who really taught me the principles of endoscopic use in aneurysm surgery, and to Dr. Medina Mujcin, who helped in review the data and presentation technical performance. So what is endoscope-assisted microsurgery? The purpose of endoscopic assistance is to improve the illumination and visibility of structures that are above the scope of microsurgery. It's very important for many cases in neurosurgery, but especially during aneurysm surgery. The endoscope has considerably enhanced the visibility of perforating arteries, which has to be kept for secure clipping, especially those which are arising from the posterior wall of ICA, anterior communicating artery, and basilar artery. If we just compare it to the microscope, it seems to me like we are always seeing the same picture with the microscope, like we are seeing the bright side of the moon. And what we want to do with the endoscopic assistance is to see what's behind, what is on the other side. From historical point of view, we know that in 1970s, Apuzzo has described the endoscope's first application as a technical aid during the microsurgical resection of suprasellar pituitary lesions. Later on by Matula and Professor Pernetsky, who also promoted the use of minimal invasive neurosurgery. What are the benefits by Professor Pernetsky is enhanced light intensity while reaching an object, and accurate depiction of features in close-up positions and extended angles of view. When we check for the literature data, we know, of course, Professor Kato has many publications on this topic, but there is also a list of other authors who have described the usage of endoscopic assistance in microsurgical treatment of the aneurysms. And when we are looking for where the most endoscope has been used, it's mostly in anterior circulation, while in posterior circulation, we use it less with the improvement of endovascular treatment. From the arterial point of view, most of the endoscope usage has been used in ICA treatment aneurysms, but also ACOM. MCA is also on the second place of this list. In terms of complications, it's a relatively low percentage of complications. Most of the patients in the literature data have actually very good outcome after this clipping. So for the conclusion of literature review, endoscope illuminate and magnify the aneurysm's morphology. It compensates clip positioning that was suboptimal or incorrect. It actually prevents incomplete completing residual aneurysm neck distal occlusion. And in this data, we found that almost 90% of patients had a good outcome. What we have starting to do here in my center is actually to do the Kivo assistance, which is an integrated endoscope of the kilowatt size microscope. What are the benefits? It's that you don't need a monitor. You can see the image on the monitor of the microscope or even on the oculars of the microscope. So we don't need a video tower. The resolution of the image is excellent. The handling is practicable and easy because it looks like the surgical aspirator. So we are all used to that. And it's entirely sterilizable. No additional wrapping is required. So I will just show you a couple of cases. This is the lady who I operated in 2021, 55 years old. She had a ruptured ICA from the left side in 2020, and on the other scan she had ICA anterior choroidal aneurysm on the right side. So here is the exposure of the right side, the ICA with the fusiform dilatation of the PCOM, but then we are inspecting the part of the ICA. So this is purely surgical image, microscopic image. So here we know that anterior choroidal anatomy is not clear purely by the microscope. So we introduce the Kivo to inspect where is actually the choroidal. So the choroidal origin is here. This is a small aneurysm on the anterior choroidal side. And then we actually measure the neck of an aneurysm and place a clip. So what we are trying to do is so-called single shot clipping. But before of that, we have to be sure where are the arteries and the perforators, especially in the ICA. So now we will inspect more of this small aneurysm and introduce the Kivo endoscope again to see that the clip position is perfect towards the choroidal artery, which is here. The perforators from the PCOM are also free. This is from anterior side, and this is from the posterior side. So those are the images, intraoperative images. This is the postoperative CT angio. So previous clipping after SAH. This is the second clip on the right side. Here is the patient neurologically intact in 1 month follow-up. When we come to the MCA, this is the case from 2023, 70 years old male with changed vessels and a large aneurysm on the MCA bifurcation. So here we may note that there are some perforators behind this aneurysm, and then we again introduce the Kivo to inspect the anatomy of an aneurysm and what is behind an aneurysm before the clipping. Here is just the phase of temporary occlusion of the MCA and placement of the clip purely microsurgically. So in this case, we see that the fluorescein has entered the aneurysm, so the clipping is not perfect. And what Kivo has actually offered us is that we know that behind an aneurysm are those vessels which we have already seen with the endoscope, not by the microscope. So then we reposition the clip and fenestrate the aneurysm with a needle to deflate an aneurysm, and the residual dog ear is closed by a mini clip. So this is the postoperative CTA where we are very satisfied and the patient went well. This is a ruptured ACOM aneurysm. Patient was Hunt-Hess 5, and after EVD, patient recovered. That we decided to go for the late clipping 1 month after surgery. This is the ACOM complex, and we can see severe adhesions after SAH. And here is the ACOM. Especially those ACOM which are pointed superiorly may hide some of the perforators behind. And sometimes we go for the blind clipping, especially in these adhesions cases. But what will endoscope Kivo will offer us here is that after placement of the clip, we may inspect something which is covered by purely microscopic image. So those are the perforators from the ACOM. The clip is here, and all of the perforators are free. So actually this helps us to confirm the good position of our clip. In conclusion, Kivo assistance clarify understanding of the aneurysm anatomical relation before clipping, which decreases the chance of accidental occlusion of the local vessels as well as the perforators. In this regard, multiple clip repositioning could be avoided, and the Kivo provides inspection of the dark side of the aneurysm, which helps us in final positioning of the clip. This is our hospital, our department of neurosurgery, and thank you for your attention.
Thank you, Adi. Very much beautiful video demonstration. And this is an endoscope assist, not pure endoscopic clipping surgery.
Yeah, endoscope assisted. Yes,
assist. Okay. Thank you very much. So maybe Kimura Sensei, can you make some comment or some advice or question? Kimura Sensei. So maybe Fukuda Sensei. Hello.
Hello.
Kimura Sensei, please make some comment or some question to Dr. Adi.
Yes. Thank you very much. This is a nice presentation. Actually, I don't use endoscope so often, but I think the checking the perforator before the clipping is the best way to use the endoscope, because some perforators are really very fragile. So sometimes when we put the clip on the perforator for just 30 seconds or 1 minute, it may cause ischemic complication. So that checking the perforator after annual clipping is also important. But I personally use the endoscope before clipping or after the tentative clipping, so the safety of the perforator is secured. So that's my policy.
Okay. So, Ali Sensei, any response?
Thank you for a nice comment. And since I don't have so much experience, I'm a young neurosurgeon. I feel comfortable with the using of an endoscope before and after the clipping, just to be sure that I didn't occlude any of the perforators which are in close proximity of an aneurysm ball. Thank you so much for your comment.
はい。ありがとうございました。Thank you so much. So we move on the next speaker, Hitoshi Fukuda Sensei. He is going to talk about hybrid operating rooms. He graduated Kyoto University, and now he is Shikoku Island, Kochi, Japan. And he's one of the best open surgeon in Japan. Fukuda Sensei, please.
Do you see my presentation?
はい、大丈夫です。
Thank you very much for your introduction. I am Dr. Hitoshi Fukuda from Kochi, Japan. Today, I'm going to talk about validity of hybrid operating room in current neurosurgery. Currently, angio-equipped operating room, which is also called hybrid OR, is available. The advantages of hybrid OR include clear angiographic imaging, smooth transition between catheter and surgical procedures, and secure hemostasis after heparinization for catheter procedure. In this hybrid OR, we use two exchangeable beds. The first one is a flat type high angio bed, where we perform the combination of a complex catheter procedure and simple surgical procedure. And we have another one. This is multi-purpose low surgical bed, where we perform a combination of complex surgical technique and simple or catheter technique. Let me show you 4 categories of hybrid OR procedures. Cerebral AVM surgery with intraoperative angiography. We also use bypass surgery plus endovascular parent artery occlusion, surgical exposure for endovascular access, and for troubleshooting. I'll show you case presentation for each procedure. The first case is intraoperative angiography for cerebral AVM to confirm nidus, sufficient nidus devascularization before dissection of the nidus. This is a case of hemorrhagic AVM, right frontal AVM of Spätzler Martin grade 4 AVM. Because there was a feeder aneurysm, we embolized it on the day of the bleeding. And then we planned to reject this AVM. On the preoperative angiogram, we only found one main feeder, and we are not sure if there are more feeders to the AVM. So at the initial stage of this surgical resection, we clamped this main feeder and then performed the intraoperative angio. But this shows there are still a lot of residual nidus flow. So it's too early to dissect the nidus. So we inspected all the lengths of the main trunk of the ACA and found around 10 short direct feeders from ACA main trunk. So we clamp it, coagulate. And then after that, repeat angiogram shows the nidus is well devascularized. So we started dissection and then total removal. The second case is also the intraoperative angiography for cerebral AVM to confirm total resection of the nidus. This is a 61-year-old lady presenting subarachnoid hemorrhage. And this lady had Spitzler-Martin grade 1 AVM at cerebral temporal surface together with the feeder aneurysm. So on the day 2 of bleeding, we embolized the SCA feeders together with feeder aneurysm. And then we decided to reject this AVM. This is an intraoperative view simulation of this AVM. We approached from the supracerebral direction. So this is a confluence of the venous sinus. And this AVM had 2 feeders, left side, 2 drainers, left side and right side. So at the middle of dissection, we cut the left drainer first, and then we removed the nidus by cutting the right drainer as well. However, intraoperative angio shows there is a residual AV shunt. We checked the angio again and found that we cut the drainer here, but there's still a residual small nidus close to the tentorial sinus. So we further rejected this residual nidus, and repeat angio shows total removal. Next, I'll show you the case of bypass surgery plus endovascular parent artery occlusion. This is a 45-year-old lady presenting subarachnoid hemorrhage. MRI shows a left side subarachnoid clot, and left ICA angio shows irregular dilatation of the carotid siphon and paraclinoid area, together with stenosis of distal ICA. So we diagnosed this is a ruptured dissecting aneurysm of supraclinoid to carotid siphon of left ICA. So the location of the aneurysm is like this, paraclinoid dissection involving the origin of ophthalmic artery. To safely and effectively treat this aneurysm, we took this clip anchor assisted endovascular parent artery occlusion. So in this strategy, first we set the high flow bypass using radial artery graft to secure cortical blood flow of the ipsilateral cerebral hemisphere after the parent artery occlusion. And then we opened the carotid cistern and put the clip on the ICA just proximal to the PCOM to prevent coil protrusion and distal embolism by subsequent coil embolization of the ICA. And lastly, we performed a coil embolization of the ICA just proximal to this clip to block the anterograde flow from ICA and together with retrograde flow from ophthalmic artery. I'll show the operative video. This is the left front temporal craniotomy, and the M2 portion of MCA is exposed now. And then radial artery graft was put through from cervical area to cranial portion. And the distal end of the radial artery graft is anastomosed with M2, and the proximal end to external carotid. Bypass is completed. And ICG angiography shows it's okay. This is the carotid cistern. Now you can see the ICA and tiny PCOM and the aneurysm behind. We put a clip on the ICA just proximal to PCOM, and PCOM is okay. And then we put the microcatheter to the aneurysm and ICA, And because of the distally placed clip, the parental artery occlusion by coil is straightforward. Next, I'll show you the surgical exposure for endovascular access. This is a 71-year-old man with symptomatic right carotid artery stenosis. He's also awaiting the surgery for his abdominal and thoracic aortic aneurysm. So as shown by this CT angio, the access to the right carotid bifurcation was really poor because of the presence of this aortic aneurysm. So we cut down the common carotid artery and inserted the guiding catheter directly. And then a stent was placed successfully. Recently, this kind of direct puncture carotid artery stenting is getting more popular in the United States, and it is also called the TCAR, transcarotid artery revascularization. This is getting more popular in this country because to avoid invasive endarterectomy, as well as to avoid access through a pathological aortic arch. Next case of surgical exposure for endovascular access. This is a case of right ICA and CCA tandem stenosis causing right side hemodynamic compromise. Because this patient had an aberrant subclavian artery directly coming from the aorta, it's hard right CCA originating directly from the aortic arch. She also had a collateral flow from the vertebral artery through vertebral artery, occipital artery. So we took the one-stage CCA stenting and endarterectomy strategy in the hybrid valve. First, we exposed the right carotid bifurcation and clamped the occipital artery first to avoid the distal embolism during procedure. And then we punctured the CCA in a retrograde fashion. And then crossed the region by a guide wire, through dilatation by a balloon catheter, and put the stent at the proximal end of the CCA. After that, we performed the endarterectomy as a usual fashion, and schematic imaging of this one-stage surgery is shown here. Finally, I'll show you the troubleshooting using hybrid valve. This is a 68-year-old man with acute left oculomotor palsy. There are no subarachnoid hemorrhage, but he had a 7mm left pecom aneurysm. So we thought this is impending rupture of this aneurysm. So we planned the surgical clipping for this impending rupture of left pecom aneurysm. After exposure of the cervical ICA and left frontal temporal craniotomy, the electrocardiogram of this patient suddenly showed a ventricular tachycardia due to atypical angina. Fortunately, his ECG recovered to the normal sinus rhythm in 10 seconds. The anesthesiologist and cardiologist recommended that we should terminate operation or we should switch to less invasive treatment. So in this case, we took this hemostasis coiling hemostasis strategy in the hybrid valve. First, we confirmed the hemostasis and closed the skin temporarily before heparinization, and then we transferred the patient to hybrid valve. In the hybrid valve, with heparinization, we coiled this aneurysm in a usual manner. After that, we opened the skin again and meticulously confirmed the hemostasis. after the skin closure, this CT-like imaging is available in the hybrid OR. So we took this CT-like imaging and again confirmed the hemostasis and extubate the patient. In summary, a hybrid operating room is helpful to treat complex or intractable cerebral vascular disorder. The advantage of this hybrid OR is clear and geographic imaging, smooth transition between catheter and surgical procedures, and secure hemostasis after heparinization. Thank you for your attention.
Thank you very much, Fukuda-sensei. Any comment from maybe Albert?
Yes, congratulations for the very nice presentation, very interesting. Actually, I have a small experience with the hybrid operative theater because I used a couple of times in my previous hospital before moving to Verona. I totally agree that it is a major adjunct, especially for vascular neurosurgery. I have a very technical, operative, I would say, question. Do you share this operative theater with vascular surgeons, general vascular surgeons, or I don't know, cardio heart surgeons, or is this hybrid surgery theater dedicated to only neurosurgical cases?
Sorry, I don't understand you. Say it again.
I mean, in our hospitals, usually we share this kind of hybrid operative rooms with other colleagues, right? Like vascular surgeons or
okay, I understand.
Heart surgeons. So is that the case also at your institution, or you have a dedicated vascular theater just for neurosurgery?
And actually, we share this room with other departments. So mainly this hybrid OR in my hospital is shared by the neurosurgeons and vascular surgeons. And yeah, sometimes cardiologists are using this room to just small surgery like a pacemaker placement or changing the battery or something like that.
Yeah. Thank you.
So Fukuda-sensei, how often do you encounter the surgery of the high flow vipers right now?
And on average, 3 to 5 times a year. A year. And actually, we are taking the a universal high flow bypass policy, so that we don't often do the a balloon occlusion test to check the tolerance of the ICA sacrifice. So we usually skip the balloon occlusion test, and then whenever we sacrifice the ICA, we are setting the hybrid or high flow bypass. So that's why that we are doing this procedure so often.
So you have enough team, so maybe you need some teams.
Yes, basically the 3 or 4 surgeons are involved in the high flow bypass at the same time, so that for example, the cervical and the radial artery and the craniotomy are done by at the same time.
So even the flow diverter is coming up. So even though maybe there you have 4 or 5 cases per year, you're a leader of the high flow bypass in Japan, I think. So please continue your techniques and teach us more. Thank you very much for your nice presentation. Thank you. So we will go on. The next speaker is George Inamasu. He graduated at Keio University. Now he is working at Utsunomiya City near Tokyo. His today's talk is Pitfall in the Management of Subdural Hematoma associated with spontaneous intracranial hypotension. Inamasu-sensei,
hello.
Hello.
Can you hear me?
Hi, 大丈夫。
Oh, ciao tutti.
That's true.
So my topic is about the spontaneous intracranial hypotension. So I think everyone knows about it. And it's defined by CSF leak as the spinal dural tear. And the symptoms is caused by loss of CSF volume. And most patients complain of orthostatic headache, which is headache worse with standing and better with the lying down. And other patients may have ear fullness or dizziness or vertigo, and so on. And basically, first we have to confirm the patient whether the patient have the spinal intracranial hypertension or not. So first we do a brain MRI with the enhancement, and usually we look for a meningeal enhancement. And after the confirmation, we usually do either mirror CT or mirror MRI to locate the CS leakage point in the spinal dura. So in the left side, you can see a very intense meningeal enhancement of the patient. And on the right side, it's the sagittal MRI scan. And you can see a downward placement of the cerebellum and the brainstem. Its patient came with the coma. And after the confirmation with the brain MRI, we do the either spinal mirror CT or mirror MRI to look for the leakage. And on the left side, this is a cervical spinal junction. And this is the leakage point here. And in the middle, it's the thoracic spine. And this is a patient with the leakage in the thoracic spine. And the right side, this is the leakage at the lumbar spine, as you can see in here. And this is a patient after treatment. So the severe meningeal enhancement has gone. And on the right side, also downward herniation of the cerebrum disappeared. And the spontaneous intracranial hypertension is mistaken by many diseases, such as the subarachnoid hemorrhage and Chiari malformation. So as you can see this CAT scan, so this looks like a SH, subarachnoid hemorrhage, but it's actually not. So the stagnation of the venous flow looks like a hemorrhage. This is both patient with the SIH, and also patients are mistaken by Chiari malformation, and so as you can see, downward placement of the cerebellum into the foramen magnum. And today my topic is about the subdural hematomas associated with SIH, and this is the same patient. The above CT scan is the when patient come here for the first time, and CT looks like normal, and in the below you can see two CAT scan, and this patient came back after 3 weeks after the stupor, after the altered mental status. And as you can see, this is the disappearance of the cradiogeminal cistern, and also here you can see a thin subdural hematoma in both sides. And so mistakes or complication often happens in this condition. So we go through several cases and learn how mistakes have taken place, and in the next, what should we do? So this is the young patient came to our clinic complaining of headache, and as you can see a thin subdural hematoma on both sides. So usually the hematoma need to be evacuated. So this is a cases about more than 10 years ago, and we done a bilateral evacuation of a hematoma. And what happened is actually, after the drainage, patient got worse, and the CAT scans show the postoperative bleeding. And so we took patient to the OR and evacuated the hematoma. This is because after the complication happened, we realized the patient actually have a intracranial hypertension. So by confirmation, we have done a gadolinium enhanced MRI, and you can see a strong enhancement here. And subsequently, the mirror CT shows the leakage in the craniovertebral junction. So after the surgical treatment, the patient got normal. And in the literature, so this is our cases, and we published this case. And actually, very same thing happened in other countries. This is a report from Korea, and on the left side, so this is the just similar cases, and the patient underwent a bilateral evacuation of a hematoma, and what happened was the bleeding you can see here. So lesson learned here is the in cases with the intracranial hypertension related bilateral subdural hematoma, bilateral drainage may better be avoided. So this is the second case. So this is the old man complaining of dementia, and so this patient is was taken to other hospital, and in other hospital, patient underwent a bilateral drainage. This is the in the middle is the one POD CAT scan, and you can see hematoma is nicely evacuated, but the patient did not get well, and on 7 POD, there is no expansion of brain. So the patient then referred to us for a consultation, and actually there is no expansion of brain, and that make us think about the intracranial hypertension. So patient have a enhanced MRI, and you can see this side very intense the meningeal enhancement, and so patient is confirmed to have intracranial hypertension. So next we move on to a mirror CT gram, and this shows a leakage on the lumbar spine. This is the axial scan. This is a leakage from the nerve root. So patient underwent a percutaneous injection of blood, and the patient got well since then. So lesson learned here is the when the after the evacuation of a subdural hematoma, when the brain does not expand for days, so we have to suspect something is wrong, and we have to suspect presence of intracranial hypertension. So this is the third cases. This patient you have unilateral subdural hematoma on the left side, and the patient was treated by a small craniotomy and the evacuation of hemorrhage. But there is no improvement after all in one POD CAT scan. And the patient actually got worse on day 3. So in this situation, so we have to suspect something is not going well, and we have to suspect the presence of intracranial hypertension. So patient underwent the enhanced MRI, and there is strong meningeal enhancement here, and so this is the downward placement of a cerebrum. So it is called pseudo Chiari malformation. And next, patient underwent mirror CT, and the mirror CT shows the leakage of the thoracic spine. And so this is the before and after the blood patch therapy. So in the upper side, in the above, there's a small line here. This is the sign called dural sign. And after the treatment, this sign disappears. So lesson learned here from this case is usually the patient have a bilateral subdural hematoma, but occasionally patient may have unilateral hematoma. So that should be remembered. And this is the fourth case. So patient is the 70-year-old man with head injury, and on the left side, you can see a thin acute subdural hematoma. So usually we treat this patient conservatively, and this is the what happened 7 days later, and this is the development of something like a subarachnoid hemorrhage here, and there is a accumulation of a subdural hematoma, and there is a brain shift here. So patient underwent the small craniotomy and the removal of a hematoma. But what happened was there you can see this is a post-op CT, and you can see accumulation of air, and the brain did not expand at all, and so there's no clinical improvement after surgery. So in this situation, so we have to suspect something is not going well, and so we take the patient this is no MRI, but there's mirror CT scan show the leakage of the lumbar spine, and the patient got well and got normal after the epidural blood patch therapy. So very similar cases reported by Korean neurosurgeon, and this is above is a small acute subdural hematoma, and the patient was treated by craniotomy. But after the craniotomy, there is still accumulation of a hematoma, and the patient underwent the decompressive craniectomy. But because the intracranial pressure is low, after the craniectomy, there is the phenomenon called the brain sinking happened. So this is the very typical mistaken. In this case, the MRI, mirror MRI was done, and this is a leakage at the also cervical spine, and the patient got well after the blood patch. So usually patient, the ages are from 30 to 50, occasionally 60, but usually younger than ordinary subdural hematoma patient, a chronic subdural hematoma, who is often from 60 to 80s. So in patient with the non-geriatric patient, there is some report showing that in a patient non-geriatric chronic subdural hematoma patient, CS leakage is found in 1/4 of patients. So intracranial hypotension should be suspected in non-geriatric patient. And also patient with the coma or patient intracranial hypotension patient with coma or altered mental status usually mostly have a bilateral subdural chronic hemorrhage. But the interesting thing is that they do not complain orthostatic headache so much. So only half of patients complains of orthostatic headache before being carried in. And in patient with subdural hematoma complicated by intracranial hypertension, usually the recommendation is that the first subdural hematoma is drained by Barreau drainage, and subsequently leakage is patched by epidural patch therapy. And usually we do a percutaneous blood patch, but in cases with the leakage at the upper cervical spine, the percutaneous is not very safe. So this is the cases with the leakage at the C1, C2 junction. And so this is the operative video. And this is the, we are exposing the muscles, and this, you can see the water is coming up from. And actually, so it's the only subcutaneous tissue and muscle, but you can see in a severe leakage, the water is seen in between the into the muscle layer. And this is we have doing the partial C1 laminectomy here. And we are peeling off the connective tissue from dura. And so this tissue is very watery. Water is coming from inside. You can see water is coming up. So so this is the continuation of laminectomy, and we try to make the skin incision as small as possible. You can see the water is keep coming up. So in this case, we locate the leakage point, and we put the, so this is the neural break in here. So we put the muscle pieces and close seal the dura. So the my conclusion is that the intracranial hypertension related hematoma are not so rare, and if there is no improvement after the subdural hematoma removal, so we have to suspect the presence of intracranial hypertension. Thank you.
井上先生、ありがとうございました。It's very interesting, the cases. So we should learn. So maybe we should know, maybe sometimes. Albert Sensei, you have some question for Shot Sensei?
Yes.
Okay. Albert first.
Okay,
Yes.
so
稲松先生、すいません。What is the last slide?
This is the
Can you explain us?
very famous sculpture in near my town. So see no evil. Well, three monkeys. This came from Nikko. My workplace is near the Nikko. So it's the UNESCO World Heritage sculpture. So I show you.
So the three monkeys, what they are telling us?
No, see no evil, or hear no evil, or speak no evil.
Okay, so keep silent, that means.
Yes, that's right.
Very good. Okay. Please, Abe Sensei.
Yes, I think sooner or later, all neurosurgeons will meet this kind of patient. It's actually a nightmare. So it was a very interesting presentation. My question is, actually, I have two questions. The first is, you mentioned myelo CT or myelo MRI to detect the leaking point. In your experience, are these exams always able to clarify the leakage point? Or if not, what do you do? And the other question is, you treat these patients using blood patch. Again, do you have always success in treating these patients with blood patch, or sometimes this method fails? So what do you do in those cases? I'm asking because we also had, of course, such experiences. So sometimes it might be a trouble to treat these patients.
Thank you for the question. Usually, I answering from the second question. So usually the success rate is about 80 to 90%. So in about 10%, there is we have to repeat the procedure. So about the 80% or 90, so we only one time epidural blood patch is good enough. But in the remaining 10% or 20, we have to do twice or third time, thrice blood patch therapy. And regarding the detectability of the MRI, either CT myelo or MRI myelography, usually CT myelography is more sensitive, but it's not always detect the leakage. But usually the larger the leakage, so usually easier, more detected by the CT myelogram. So when in patient with the occult leakage, when we cannot pinpoint the leakage point, usually the leakage is small. So those patients are usually treated conservatively. So that is that good enough for your answer?
Yes, yes. Thank you. Thank you.
Sensei, please.
Sensei, thank you so much for the interesting lecture. My question is, I was interested, what is the reason of this spinal CSF leak? In case of, basically this is trauma cases, maybe this is because of the concomitant trauma, or there is another mechanism behind?
So usually the spontaneous means the without the any causes, but the even in those cases, usually trivial trauma is related. But in some cases, in patients with the connective tissue disorder, such as the Ehlers-Danlos, so they may present with the this symptom. So usually, mostly, I guess, the trivial trauma is the causative. But in other patients, the such the connective tissue disease may be the occult cause.
Okay, thank you so much.
Thank you.
ありがとうございました。井上先生、please continue such kind of a very interesting case report
Thank
in
you.
future, please. ありがとうございました。So we move on to the next speaker, the Hidehito Kimura sensei. So current aneurysm clipping on the preoperative simulation and improved techniques. He's an excellent clipping surgeon in Japan now. Kimura sensei, どうぞ。 Kimura Sensei? So we don't see the Kimura Sensei. Kimura Sensei?
We just have to promote Professor Kimura.
Thank you. I
Okay.
re-entered again. Sorry.
Hi,
I'm
please.
sorry, my absence. Yeah. Thank you.
どうぞ。
Yep. So I want to show my screen here. Can you see my slide?
はい、大丈夫です。
Thank you. So it's my always great pleasure to present my topic on the fantastic ACNS webinar here. So I deeply appreciate Professor Yokokato. I deeply appreciate and Professor Liu and Raja. Thank you. And today my topic is the current aneurysm clipping and the preoperative simulation using a computational-free dynamic analysis and CT venography, high-resolution CT venography. I will show you here. This is my Kobe city here, very, very close to Osaka city, Tokyo here, and Nagoya here. Professor Yokokato is here. So very close city in Japan. So we have good communication each other. It's usually academic meeting. So this is a typical unruptured IC anterior corridor artery aneurysm. Sorry. You can see the anterior corridor artery is branching from a little bit away from the neck. So the interventional surgeon asked me to perform the direct surgery for me. And when you treat this patient, treat this aneurysm, we always perform the so-called telionar approach. So in the telionar approach, we have to dissect the Sylvian fissure widely in between the Sylvian veins. These Sylvian veins could not be predicted so far. So once you open the dura, and you notice the venous anomaly, venous variation intraoperatively. So in that situation, you have to decide which plane should be dissected. So, but in this presentation, I will show you we can detect preoperatively using the CT venography, high resolution CT venography. You know, the Sylvian veins has several variations, so it could not be detected preoperatively. Even the Professor Yashagil described his book, the Sylvian veins was frontal branching vein was cutted. If I do so in the current situation, the postoperative venous congestion in the frontal lobe may occur. So may the patient suffer the postoperative bleeding, intracranial bleeding due to the venous congestion. So to avoid this such a complication, we have to preserve all kinds of vein to predicting the any kinds of venous anomaly. The second my topic is the computational-free dynamic analysis. Recently, I noticed we reported that using a computational-free dynamic analysis, CFD analysis, we can see the preoperatively the aneurysm thin walled region and the thick walled region like this. So in the treating this aneurysm, the thin wall causes to the high risk of intraoperative rupture, and the thick wall causes to the incomplete occlusion after applying the clip, and sometimes thromboembolic source and branching visceral occlusion. So we have to know preoperatively these wall properties using the CFD analysis. So using two materials, two modalities, we have to eliminate uncertainty as much as possible preoperatively. So this is a Canon Aquarium CT cutting-edge CT machine. We can use this machine to see the very, very tiny structures we can see preoperatively. Using this CT scan, we can simulate the any kind of venous variation, and also, of course, the small, tiny arteries and branching, anterior coronary artery also detected using this high resolution CT angiogram, CT venography. So preoperatively, we can see the dissecting plane in between the Sylvian veins. So as for the aneurysm wall, it is well known the aneurysm wall properties can be divided to 5 grades. The grade 1 is thin wall, and the grade 2, grade 3, grade 4, 5 is a little bit thicker in order. The grade 5 is a yellowish and so thickened wall area. We can simulate preoperatively these properties. Sorry. So this is one of the CFD parameter, wall shear stress vector cycle variation. So in this presentation, I will describe the WSSVV. And using this parameter, we can see the low value area can be predicted as a thin-walled area. And the high value area can be predicted on the thick-walled area, sorry, here. The low value area is a thin-walled area, and the high value area shows a thick-walled area. So using this equation can be calculated to this color maps. And this statistically significant. It's a qualitative analysis you can see here. Another parameter, this is the oscillatory shear index, so-called OSI. This is also the similar parameter, WSSVV. The both parameter reflect the stagnation of the blood. So it means that around the high value area, it's a little bit stagnated flow inside the aneurysm wall. In the stagnated portion of the aneurysm wall causes your aneurysm wall thickening. Recently, we published this data. And using this OSI, we can see the difference, statistically significant difference between two walls. Thin wall is a low value areas, and thick wall is a high value areas. So accuracy rate is about 80 to 90%. So high level of accuracy. Using this parameter, we simulate the aneurysmal properties preoperatively. This is the first case is as mentioned in the unruptured anterior coronary artery aneurysm. And to treat this patient, to treat aneurysm, this aneurysm projected posteriorly. So to treat this aneurysm, if we choose a subfrontal approach, we cannot see the anterior coronary artery branching site. So we have to choose a more lateral corridor, surgical corridor. We have to select the more lateral corridors. So we have to perform the anterior temporal approach for this aneurysm. So anterior temporal approach is widely well known recently also, that we have to dissect the Sylvian vein widely, and the temporal lobe are retracted posterolaterally, and we can see the lateral to the ICA, the posterior wall of the ICA from the lateral corridor. So as in this surgery, I simulated the surgical corridor. The patient has two Sylvian veins, main two Sylvian veins. There are several bridging veins from the temporal lobe to the Sylvian veins. So we have to dissect this plane in between two Sylvian veins. If I dissect this plane, there's no bridging veins. I can see. Just to dissect this root here, it's okay. And what about the aneurysmal properties? This is the anterior facing side, head facing wall is a little bit thickened wall area. And the portion of the branching side of the anterior coronary artery a little bit consists of the thick wall area. I can simulate. And this is in the actual surgery after the front temporal craniotomy, and frontal lobe and temporal lobe, two cerebral veins were detected as predicted preoperatively. And I dissecting the cerebral veins sharply. And meticulous technique and the highly magnified inspection, of course, very important to see the surgical field clearly. As possible, as less bloody surgical field is also important to perform the safe surgery. So this is a simulated plane, the same plane as simulated, just this dissecting two cerebral veins. There's no breaching veins. And this is I dissecting the temporal lobe between the cerebral veins, and this is the tentorial edge. And approach to the aneurysm. This is a relatively thick walled area here. In the just a facing wall is a little bit thin walled area. I will show later. So as I simulated, this is a thick walled area here. The branching portion is also the thick walled area. To occlude the branching of the anterior corridor artery, a clip was inserted a little bit away from the branching portion of the anterior corridor artery. So endoscope inserted the patency of the anterior corridor artery, and the operation finished. And the facing wall is a thin walled area, and the branching portion is a thick walled area. That's similar, accurately predicted. Postoperatively, there is no infraction, no hemorrhage. The patient postoperative course uneventful. And you can see the CT angiogram, the aneurysm disappeared. Okay, and I reviewed the CFD analysis and the intraoperative view. As I mentioned, the facing wall is a thin walled area, and the neck around the neck is a little bit a thick walled area as the simulated. And the branching portion of the anterior corridor artery is also thick walled area. The next case is a bilateral middle cerebral artery aneurysm case. And to treat this aneurysm, I choose the ipsilateral approach to both aneurysm. So some authors already reported the ipsilateral approach to the both bilateral middle cerebral artery aneurysm. The important point is that contralateral aneurysm should not have no arteriosclerosis. No arteriosclerosis is important point for the contralateral aneurysm. Of course, anterior projecting and a short M1 is also important. So I simulated this aneurysm. This is an ipsilateral aneurysm. Aneurysm domain a little bit thick walled area may be predicted here. And the contralateral aneurysm, what about the contralateral aneurysm? Left middle cerebral artery aneurysm. And this is aneurysm neck. And the back side of the neck, a little bit thick walled area maybe exists here, as I simulated preoperatively. And this is the intraoperative view. The right Telner approach was performed, and the cerebral vein was sharply dissected automatically. This is the ipsilateral MCA was found and dissected. And just dissecting the frontal lobe, the cerebral fissure, and this is the M1 portion here, and cerebral fissure is widely opened. And the right optic nerve, and to access to the contralateral side, this is the left optic nerve, and approaching to the contralateral side, cerebral system was opened, left cerebral system was opened, and you can find the aneurysm. So as I simulate, there is no apparent thick walled area around the neck, and maybe backside of the neck, maybe thick walled area will exist. So the neck was dissected, and the clip was inserted, apply the clip, and the endoscope was inserted to confirm the backside. Now here you can see the arteriosclerosis of the backside of the neck. And finally, ICG video angiogram demonstrated no filling of the aneurysm dome and approach to the right ipsilateral side. So as simulated, the aneurysm dome had a yellowish thick rod area and dissected further. The clip was applied. So because this aneurysm has a thick rod area partially, so I need to apply multiple clip for this aneurysm dome because ICD just a single clipping was not occlude completely the aneurysm dome. 2 clip was applied, punctured, still bleeding. So I need to apply 1 more clip. So this aneurysm, the ipsilateral aneurysm is okay, but if it happens contralateral side, maybe complicated surgery. So pre-operative aneurysm wall properties prediction is important to approach this aneurysm, this kind of surgery. The postoperative CT demonstrated there is no infarction, no abnormal event, and the CT angiogram demonstrated aneurysm disappeared completely. And the third case is like a paracrinoid aneurysm, like here, and the ruptured case also. And the important point is that this aneurysm has attached to the anterior cranial process here, and just like a paracrinoid aneurysm, but it's not actually paracrinoid aneurysm. The angiogram demonstrated the twig-like MCA, so-called twig-like MCA. You can see here, show here. So, and interventional surgeon asked me to perform direct surgery because a flow diverter cannot insert it to this portion to do this anomaly. So this, you can see that this is IC PC aneurysm. Until this actually ICPC aneurysm. And you can see that through PCOM aneurysm here, small PCOM aneurysm here. And this calculated, measured like this, aneurysm about less than about 10 millimeter. The small PCOM aneurysm here. This is the ICPC aneurysm. So also the patient suffered twig-like middle cerebral artery and middle cerebral artery. So the patient suffered left cerebral insufficiency, close to sometimes patients suffer the ischemic event. So we have to perform the STMC bypass in advance in this surgery. So about the management of the both aneurysm, how to treat this aneurysm. So to see the true PCOM aneurysm intraoperative directly, I have to decompress this aneurysm. So I choose the suction decompression technique. So this is a traditional way to perform. Like Professor Otani also reported, the ice carotid artery, EC, IC, clamped, and punctured, and cannulated, and evacuate the blood, and the aneurysm decompressed, and perform the safe surgery. But in another way, so far I have to perform this way to EC, IC clamped, and the superior thyroid artery cannulation was inserted to decompress the aneurysm. But in this surgery, I have to perform the STA, MCA anastomosis. In this, if I use these techniques, intraoperatively, STA was declamped because the ECA was clamped. So we have to, while keeping the STA intraoperatively, and the ICA should be occluded also. So I choose to, in this surgery, using this technique, using the shunt tube, we usually use carotid endarterectomy. So if I use this technique, the ECA was opened, keeping the open, and the ICA was occluded using this balloon tube. So in this surgery, I use this shunt tube. And this is the surgical planning here. And as I mentioned, and what about another point, another problem for this aneurysm? This aneurysm is originally has a calcified region on the anterior wall here. So CFD analysis showed also this portion is a thick walled area here. And also this aneurysm has this is the backside of the neck. So this also aneurysm has a thick walled area backside of the neck. So I plan to clip for this aneurysm. The fenestrate clip first inserted here over the facing calcified region. And additionally, the parallel to the straight clip was applied to occlude the aneurysm completely. The patient positions spine and then usually standard the technique. And first I secure the IC, EC, common carotid artery, and the STA was harvested to perform the STA by STA-MC anastomosis. After craniotomy, to perform the extradural anterior craniodectomy. But the tip of the anterior cranial process is attached to the aneurysm dome. In this extradural procedure is a partial removal, just a partial removal of the anterior cranial process. The tip adhered to aneurysm dome. So to avoid this portion to extradural removal. So after that, opening the dura, I perform the STMC anastomosis. Very important point. When you insert a needle and a higher magnified region, when you're tying a thread is a lower magnified region inspection. So after confirming the patency of the STMC bypass, and the dura was opened and confirmed the aneurysm dome, and the tip of aneurysm anterior coronary artery was removed. This is optic nerve here. This is the aneurysm here. This is the anterior. Here is a distal ICA. I see anterior internal carotid artery here. That after removing the anterior carotid process completely, the further dissection. And after, as I know, I find that there are picomartery, distal picomartery here, and distal IC here. And after that, I cannulated the cervical ICA using the carotid endarterectomy shunt tube. And distal picomartery and distal IC clamped, and the aneurysm decompressed. And using this technique, very safely applying the clip, not to avoid the rupture. You can see any anatomical structure around the aneurysm dome. The posterior wall of the aneurysm dome is also dissected safely, and this is the anterior cranial process here, you can see. After that, I medial to this aneurysm, dissecting here, and this is the pituitary stalk, and the portal vein is here. And finally, I can find the true PCOM aneurysm here. Once you expose these kind of structures, the clipping application is very easy, not so difficult. As I simulated using the fenestrated clip, the clip was applied over the facing calcification region. And additionally, the straight clip was inserted to distal to the original initial clip. ICD confirmed the complete clip occlusion closure of the aneurysm dome. And post-operative, there is no event, no hemorrhage, no infraction, patient doing well. And ST was also patent on the MRI showed. This is another case is a 32-year-old female woman presented consulted to our hospital to treat the multiple aneurysm. Because she had the multiple aneurysm, left side aneurysm, small aneurysm also here. So I choose to the contralateral side to treat this aneurysm, paracranial aneurysm also. This aneurysm simulated the anterior wall is a little bit thin walled area. And at what point, another problem is the aneurysm is a very, very small, tiny, but a very, very thin walled area. this is here is if I choose a contralateral approach, this is a blind portion. So I know some portion is a thin-walled area, backside of the neck. So as I simulated here, sorry, this is a 12 grams here. This is maybe a thin-walled area, maybe will exist. So intraoperatively, this is a contralateral approach. To the right, I see paracranial annular medial protrusion. And as I simulated, this is the thin-walled area, that the frontal wall of the aneurysm. I dissected the dome and confirmed the backside of the neck, very, very thin-walled area. Small bleb was exist. So I noticed, preoperatively, I know this thin-walled area. So the clipping was safely performed. The endoscope inserted to confirm the complete occlusion. So this is the final case is this also unruptured the ACOM aneurysm. This aneurysm also predicted using the computation fluid dynamic analysis. The tip of the dome will consist of thin-walled area, and the neck will be thick-walled area. These two color map shows. The intraoperative view is also this accurately predicted. The dome of the tube bleb is a thin-walled area, and the neck is a little bit thick-walled area. And this operation was performed by my colleagues, younger colleagues, and I supervising for this approach, for this surgery. And he dissecting the thin-walled area around here, but unfortunately the rupture occurred. So we have to know, of course, the thin-walled area around the neck, around the aneurysm, very, very, very critical point to this dissection, this and around this. We have always talking in this interoperative for my younger colleague. But it could be predicted, and there is no problem post-operatively. That CFD parameter actually accuracy predicted, accurately predicted, sorry. So in conclusion, high definition CT venography can navigate us to select an optimal plane to reach the aneurysm. Preoperative CFD analysis can accurately simulate the wall properties. These allow us to perform more accurate and safe surgery by eliminating the preoperative uncertainty. Thank you for your attention.
Kino-sensei, thank you so much. It's very informative, very good lecture. Thank you so much. Your video is so beautiful and there are so many tips. Adi, any question to him?
Thank you, Professor Kimura. We have hosted you for a couple of times, and you are always a great lecturer, and we are really fascinated with your techniques which you use. Sylvia and Fisher, this section may be always some dilemma where to open and how to pass these veins. I have a question regarding the contralateral MCA, since we also do it in unilateral craniotomy. Which would be your exclusion criteria to decide on unilateral approach when you see mirror MCA aneurysms preoperatively? What is your strategy? And the other question is regarding the premature rupture of an aneurysm. If we don't have the CFD analysis, as you showed us, which would be the best strategy to avoid thin wall of an aneurysm to have the premature rupture in aneurysms? And thank you.
Thank you. Thank you for your question. It's a very important point. You have two also very important point. The first question is to perform the contralateral approach for the MC aneurysm. So in the exclusion criteria, it may be the longer middle cerebral artery. Of course, is not a good point, not good for a contralateral approach. And also the aneurysm dome projected superiorly is not good good indication for the contralateral approach. The good indication for the contralateral MCA is a short M1 and the aneurysm dome projected front anteriorly. And the aneurysm, of course, is not so large. Maybe is less than 5 or 6 millimeter is better. more than 6 or 7 millimeter, you should perform the ipsilateral approach, I think. So contralateral aneurysm is very, very sometimes hazardous, too dangerous to perform. So in such a situation, we have to both craniotomy in another situation, in another term. So, and the second point is to avoid the intraoperative rupture is the symbol region. Of course, we have to perform the blunt dissection is sometimes puncture the symbol area. So I recommend to perform the sharp dissection. And of course, the intraoperative blood pressure is of course important. High blood pressure may cause to the easily intraoperative rupture. So usually I ask to anesthesiologist to decrease the blood pressure sufficiently. And of course, the dissection should be performed meticulously and sharply. So blunt dissection is not good to avoid the intraoperative rupture. Thank you.
Thank you, Professor Kimura. It's a very good point for vascular neurosurgeons. And also we have a question from Professor Felletti. So please, Professor Felletti, you may proceed with your question.
Thank you, Adi. Hello, Hidehito. Good to see you.
Thank you.
I have a comment and one question. So the comment is about CFD. Actually, we also had some years ago at Fujita University similar results about low wall shear stress associated with thin wall. However, I remember this was not true all the times. And actually, you also showed that the accuracy of this method is maybe 80, 85, 88%.
Yeah, right.
So maybe I would say that this CFD analysis is useful for preoperative planning, but not yet useful for deciding whether to treat or not a patient with an unruptured aneurysm. So maybe you can comment on this. And my question is about the anatomy of the cilium veins. Of course, it's very important to know preoperatively the anatomy also of the cilium veins. So my question is, how accurate is this method you showed us with this high resolution CT scan? So in your experience, was it always reliable, or do you think in some cases it's not yet perfect? Thank you very much.
Thank you. Thank you for your excellent two questions. So your first question is a good point, of course. Yeah, to preoperative simulation for using the CFD analysis is very good. So as I mentioned, so in the future, so aneurysm decision to treat or not is very important point. I think it's not achieve the consensus. Just performing the foregoing study, so ongoing study. So I just knowing about the decision making to treat or not treat this disease and ruptured aneurysm. It's a good point. Thank you. And the second question is, sorry. So it's CT.
The accuracy.
High resolution CT venograph is always right. Always, of course, always right. There's no lie, and we can rely on the every structure in detail. But more small tiny vessel cannot see on the even in the high resolution CT venography. But once you notice the small anterior collateral artery and small lenticular artery, and it's also right once you see that vein. But we cannot see some more tiny, more smaller vein cannot see. Yeah, it's maybe a problem. So next,
but to decide how to dissect the cilium veins, this method is always reliable, you say?
Always. Oh yes, that's right. Always.
It's very, very interesting.
Yeah, thank you.
Thank you.
We have one more comment and question from the audience. Professor Kimura, please. Thank you. It says, thank you, Professor. Excellent talk. Does flow vector, wall shear stress vector direction coincide with OSI findings?
Yeah, very important point. Yeah. So first, I have to mention about the difference between the WSS and the WSS-VV is a completely different parameter. The wall shear stress and the wall shear stress direction variation, vector cycle variation, VV, is completely different. And the WSS-VV is a similar parameter, is OSI, very correlated with two parameters I shown in the papers. So very, very similar.
Maybe you can send your paper to Addie, please.
Sorry.
Okay.
Yes, thank you. It's just
Okay.
published,
So
actually
we should
submitted, and
yes, already
reviewing now. Yeah, thank you.
So we should proceed the next speaker. ありがとうございました、木村先生。
ありがとうございました。
So the next one is a very exciting speaker. I'd like to introduce Hiroki Morisako sensei. He is a colleague of Dr. Goto sensei from Osaka. His talk is endoscopic transcranial keyhole approach for meningiomas. I think he has really lots of cases. We are looking for your lecture, please.
Okay, thank you for your kind introduction. My topic is endoscopic transcranial keyhole approach for the meningiomas. So recently, the endoscopic surgery has been introduced in the management of the intracranial region with increasing the indication. So we just started this procedure recently. From the 2019, we started the endoscopic keyhole approaches for intracranial regions. Today, I just focus the meningiomas. So I will show these of some of the cases. So first, I will show the endoscopic supraorbital eyebrow approach for anterior scalpous meningiomas. This is a case of the anterior scalpous meningioma arising from the pranum sphenoidal. The size is relatively large. This is the surgical procedure. We make the eyebrow ski incision and make the small craniotomy 3 centimeter by 3 centimeter and access the subfrontal root. So this is the surgical video. We make skin incision eyebrow and make the small frontal craniotomy and cutting the matter and inserted the endoscope. At first we detach and devascularize this tumor, and after that we started to the internal debarking of the tumor as like the manner of the transcranial conventional microscopic surgery. After the complete detach of this tumor, so the tumor completely devascularized, so we can easily manage the bleeding from the tumor. After peeling off the tumor from the frontal lobe, we additionally perform the internal development. The deeper side, we identify the optic nerve. So we remove the tumor piece by piece like this. So the tumor gradually completely devascularized. So the color changed the white. So we manage this tumor without any trouble. So we coagulate the feeding artery for the tumor. So the dissection was performing like this, and the tumor was removed piece by piece. This is a final piece of the tumor. So finally, we achieved the gross total removal of the tumor. Usually, I reconstructed the skull base by using the fat graft. So this is a post-operative MR image. The tumor was completely removed, and the patient showed any neurological symptoms. So second, this is a relatively small size tuberculous cell meningiomas. So the patient show the visual dysfunction, especially the right side. So in this case, we apply the endoscopic procedure. So for the tuberculous meningioma, by using an endoscope, we can drill out the attachment of the tumor like this, and also we open the optic canal like this from the ipsilateral side. So both sides we can expose the optic nerve like this. So this is a surgical video. So we make the small frontal craniotomy, and so expose the dura mater and cut the dura and enter the subdural space. At first, we expose superior wall of the orbital wall, and at first we cut the dura mater, and so drilling this part. After this procedure, we could enlarge the surgical working space at the subfrontal space, and also we expose optic canal before expose the tumor. So we remove the bony structure around the optic canal, and also we drill the tubercle musela. And after that, we open the optic canal. So the optic nerve completely decompressed before the tumor resection. So after that, we started to remove the tumor. So the tumor already devascularized and detached. So and the tumor size not so large. So tumor removal is relatively not so difficult. And also by using the endoscope, we can identify some of the tumor invading the optic canal. So we achieved the symptom grade 1 tumor resection by using the endoscope. So this is after the reconstruction. So this is a postoperative MR image. A tumor was completely removed, and her visual function got improved. So we already published the detail of this procedure last year. So please check this. So next, I will explain the endoscopic subtemporal keyhole anterior transpectrosal approach. So this is the newly procedure that we make the small craniotomy at the temporal side and enter the subdural space and expose the trigeminal nerve. And after that, we cut the dura mater medial side of the GSPN and expose the triangle of the Kawase. And after the drilling that part of the bony petrous apex, we cut the SPS and tentorium and make the surgical view, the same surgical view as the conventional anterior transpectrosal approach. So this is the one case of the petrous apex tumor. This patient showed the uncontrollable trigeminal neuralgia after the gamma knife. So the tumor size are not so large. So we applied the endoscopic procedure. So I will show the operative video. So we make the small temporal craniotomy and cutting the dura mater and enter the subdural space. At first, we evacuate the CSF gradually and reach just above the trigeminal nerve, and also we check the GSPN by using the facial nerve stimulation, and we cut the dura mater of the medial side of the GSPN and expose the petrous bone, especially around the triangle of Kawase. So this is a trigeminal impression. I already exposed Kawase triangle, and after that we started that's the small part of the bony structure, and so the reach to the dura mater of the posterior fossa. So after that procedure, we can cut the SPS and also the tentorium. So we cut the dura mater along the posterior edge of the tumor, and so we started the tumor removal. So the internal development of the tumor, we cut the tentorium over the medial side, and so we cut the tentorium insula and identify the fourth nerve. And so this is the anterior edge of the tumor. We also cut the tentorium, the anterior side, and we remove the tumor completely. So like this is the final piece. So we started, again, we checked the trigeminal nerve, the SCA compressed the fifth nerve. So we additionally transpose SCA, and the microvascular decompression was achieved like this. So after this procedure, we can identify the sixth nerve, and also the seventh and eighth nerve were confirmed through this endoscope procedure. So the reconstruction is performed by using the fat graft and finish the operation. So this is the postoperative MR image. So there are no regional tumor, and the patient facial pain completely improved just after the operation. So this is the endoscope key for lateral subosseous approach. So this is a case, relatively small, the petrous meningioma. We applied this tumor for the endoscopic lateral subosseous approach. We make the small craniotomy and inserted the endoscope. So through this procedure, so we could remove the tumor, but this is the petrosal vein. So that's the very dangerous structure. So we should preserve the venous flow. So we removed this tumor. Simpson grade 2, the tumor removal was performed. So after the operation, patient showed that there's no symptom, and this procedure is so good indication for the falcium meningioma. So we usually access this tumor through the contralateral side. So this is a surgical video. So we make the linear skin incision and small craniotomy, and introduce the endoscope. So interhemispheric side, so we cut the falx and enter the contralateral side, and we reach the anterior edge of the tumor, and also we cut the falx, the posterior side, and expose the tumor gradually. At first, we detach of the tumor and devascularize this tumor by using the QSER, and gradually mobilize this tumor, the surgical approach side, and so after the cutting the posterior edge of the attachment of the tumor, the tumor was well devascularized. So we peel off the tumor surrounding the structure, and so continuous internal developing of the tumor was performed. So after the internal developing of the tumor, we could dissect this tumor from the corpus callosum. And also the surrounding the arterial, the structure gradually. So the tumor getting smaller. So this is the final piece. So we achieved the gross total removal of the tumor through this endoscopic procedure. This is the post-operative MR image. The tumor completely removed without any brain damage. So the craniotomy size very small like this. So we already published this procedure. So please check it. So the basic concept of the tumor removal of meningioma. So there are two important factors: how to access the center of the tumor and how to detach and develop of the tumor. In such a consideration, usually we select the surgical approach that does not beyond the important neurovascular structures. And so also the forehand surgery is very important for the performing the endoscopic keyhole approach. So when we plan the transcranial keyhole endoscopic procedure, it is very important to the balance maximum tumor removal and minimum invasive with preserving the function. And also the forehand surgery enables meticulous dissection of the deep-seated tumor with safe surgical corridor in cases with selective lesions. So in conclusion, the endoscopic keyhole approaches for intracranial regions considered to be one of the new surgical techniques that can be expected to develop in the future. Thank you for your attention.
Thank you very much, Morisako Sensei. It's a beautiful video. Thank you so much. So maybe Agnes, endoscopic expert, please.
Not so expert as the colleagues. I really appreciated this presentation. Thank you very much, Professor Morisako, because
thank you.
You showed excellent surgery, and you showed how much endoscopy developed recently. Just one comment, and maybe you also can comment about the importance, if you select an endoscopic approach, to preoperatively assess whether the case is suitable or not, because you showed us that it's possible to do wonderful operations with just a keyhole approach and an endoscope, a fully endoscopic technique. But it's also very important to select the right indications, especially if you go through an eyebrow approach. We need to know which are the limits of the pathology that better fit this kind of approach. Maybe you can comment on this.
Okay. Thank you for your kind comments. So yes, so I think the case selection very important. So maybe at first the anterior skull base meningioma a little bit the good indication for this kind of the endoscopic keyhole surgery, because they are not so important structure around the anterior skull base. So, but if the tumor very large or the tightly adhere the optic nerve or the anterior cerebral artery, that is not a good indication. So we usually select relatively the small to medium size of the tumor in this procedure. And so the subtemporal, the anterior transpectoral approach, this is a very newly procedure. So I think it's a very more difficult procedure. Anatomy is relatively complicated. So this is a very understanding, and also maybe for hands, the technique is very important factor. And also if the tumor located posterior cranial fossa, so tumor, if the relatively large, it's also very dangerous situation. So maybe the conventional microscopic surgery is more suitable. So of course this indication maybe gradually expanding in our institute, but so maybe in nowadays, so maybe the small to medium-sized tumor is a good indication for such endoscopic procedure. That's my comment.
Thank you.
Little shot.
Yes, thank you so much, Sensei, for interesting presentation. Very challenging cases using endoscopic approaches. Have a question. Have you ever had experience with the use of intraventricular tumors or pineal region tumors using pure endoscopic technique?
Yes, so thank you for your question. So we already performed some trigon meningioma. So by using this endoscopic keyhole approach, that is also in our impression that very well work. So I think that is one of the good option for the trigon or the meningioma. But so if the tumor located the pineal region, if the tumor is relatively small, that is also the good indication. So we already have some experience for the relatively small midbrain cavernous angioma. We already did perform the tumor resection through the endoscopic occipital transtentorial approach, and that is and also if the tumor is a falcotentorial lesion. So sometimes the tumor is relatively large, but so if the pathology is a meningioma, we can apply that part of the tumor. So that's of course the next step for our procedure. But so I think that part may be the good indication for near future. I think that's my comment.
Okay, thank you.
Thank you very much, Morisawa Sensei. So please continue your the surgical procedure in the future, please.
Yes, thank you.
So, teach us again. So maybe Dr. Adi?
Thank you, Professor Marsako. Great lecture, and it's really inspiring for especially young neurosurgeons to keep developing the endoscopic approaches in the future. Thank you so much. If we don't have any more questions, I would like to introduce Mrs. Hanna Rizvanovic, who is just doctor to graduate, and she is one of the ladies who is very interested in neuroscience and neurosurgery. I believe Professor Kato is a great motivation for her as well as for other group of ladies, because in Southeastern Europe, we are missing ladies in neurosurgery. For example, in Bosnia, we have only 3 attending neurosurgeons who are ladies, and there is also the other group of young people, young ladies who are interested, like Mrs. Emma, Mrs. Eleonora, and other. So please, Hannah, I believe this is maybe her first appearance online to have a chance to present our great work, which has been supported by Professor Kato and which has been published in ACNS. So please, Mrs. Rizvanovic, you may just continue with your lecture.
So good afternoon, everyone. First of all, before I begin, I want to express my sincere gratitude to Professor Kato, who is my big motivation and kind of a role model. And also, I would like to say that this is a huge honor for me to be able to present in front of such an exquisite neurosurgeons, and especially as a woman, since, as Dr. Ahmed Spahic mentioned, women are a minority in this field. So without further ado, I would like to start presenting our research on the topic robotic scope-assisted microanastomosis in a chicken leg model that was recently published in Asian Journal of Neurosurgery. So this is a clinical center of University of Sarajevo where all the procedures that I'm going to present to you today were conducted. And this is my university of SST, that's been validated by the University of Bosnia. And also a special thank you goes to Professor Felletti, who gave me the opportunity to do the student observership under his mentorship at his Department of Neurosurgery of the Trento Hospital in Verona. As for disclosure, we have nothing to disclose, and all authors have no financial or commercial interest. So to begin, the operative microscope has been a necessary and irreplaceable tool in neurosurgical operating room for decades. However, the daily progress in technology and the need for better optics and visualization led to the development of the exoscope. With the exoscope, the surgeon was given a wider field of the view, and with the introduction of the 3D exoscope, the surgeon was given high-resolution 3D image. So therefore, the new robotic scope combined exo microscope robotic scope was developed in 2020, and it has been in use in the neurosurgery since then. So this here is a helmet of the robotic scope, and this is robotic scope itself, body of robotic scope, 6-axis robotic arm with 2 video cameras attached to it. And helmet is also connected to the foot pedal that is being pressed when there is a need for robotic arm readjustment. So this is an official video of the robotic scope just for easier presentation. These are 2 helmets for the surgeon and for the assistant. This is robotic scope in the background, robotic arm with 2 video cameras attached to it. These are binoculars that are being adjusted. And now we can see with a simple head movement, he's moving and readjusting the robotic arm, and we can appreciate that physiological position of a surgeon is maintained throughout the whole surgery. And again, simple head movements for the readjustment of the robotic arm. When it comes to our methods, the study was conducted at the Department of Neurosurgery of the Clinical Center of University of Sarajevo in 2023 in 1-month trial period of the device. This study showcases 10-vessel microanastomosis training on a chicken legs using the robotic scope. The aim of this study is to demonstrate feasibility of the robotic scope without comparative analysis to the standard operating microscope. For the purpose of the study, we evaluated occlusion time, bypass patency with iodine, and overall satisfaction of the trainee in terms of precision of automatic focus, mobility of the device, ergonomics, and convenience of the helmet. When it comes to our results, the first table shows assessment of robotic scope. I'm just going to point out the most important things. So 10 robotic scope assisted microanastomosis were done, 6 end to side, 3 side to side, and 1 end to end. Occlusion time significantly improved with the training from 50 minutes to 24 minutes. When it comes to significant contrast leakage, it was present only 1 case, and that case took the longest, but it was controlled with 1 additional stitch. Table number 2 shows technical details in surgeon's report. So zoom used for stitching was greater than zoom used for making the knot. Camera distance ranged from 300 to 600 millimeters. When it comes to head and neck ergonomics, it was satisfactory. However, in 3 cases, a mild tension-like discomfort was present, and those 3 cases required a relaxation of the glasses strip and glasses repositioning. So picture number 1 shows laboratory for the training at the Department of Neurosurgery of the Clinical Center of University of Sarajevo. Here in the background, we can see a robotic scope, robotic arm, and 2 video cameras, and also foot pedal. This is a surgical chair and surgical table, and picture number 2 is Dr. Ahmed Spahic working with a robotic scope. And here we can see microsurgical instruments, a helmet, and a chicken leg model. The first case is end-to-side microanastomosis. This is donor vessel, and this is recipient vessel. And this is actually STA-MCA bypass training. So you can see here, after iodine administration, we can see that there was no leakage at the site of the anastomosis. Leakage was present at the proximal part, but this part was open, so the leakage was expected, but no leakage was present at the site of the anastomosis. This is another example of side-to-side microanastomosis. This is a recipient vessel that has been prepared and opened. The purple color is used to mark the edges of the fenestration in order to imitate a live situation. 2 temporary clips were used, and and also fish mouth technique is used for this microanastomosis. On this picture, we can see a donor artery, donor vessel, and recipient vessel, and also microanastomosis. And here we can see that after iodine contrast administration, there was a leakage at the distal part, but the leakage was controlled with one additional stitch. This is an example of side-to-side robotic scope microanastomosis. We have two arteries that have been dissected and prepared for the anastomosis, and simple interrupted stitch was used for suturing, and there was no gap at the proximal or distal portions of the anastomosis. So several other procedures were done after the training with the use of the robotic scope. I'm gonna present to you some of them. The case number 1, here we can see on the sagittal CT scan, disc extrusion at the level L4, L5, and we can see dilation of the urinary bladder. Here we can see axial CT scan and large extrusion that obliterates the left lateral recess. So Dr. Ahmed Spahij performed a robotic scope assisted lumbar microdiscectomy on this patient. We can see the extraction of the degenerated disc, and here we can see the spinal nerve, and again, a high resolution quality image. And now we can see after instant zoom, there is a preservation of the high quality of the image, even after high magnification. And now he's resecting the remaining of the disc. So case number 2, here we can see preoperative sagittal, coronal, and axial scans that demonstrate large sphenoid wing meningioma. So Dr. Ahmed Spahij again performed robotic scope-assisted meningioma resection. Here we can see dura and the tumor also, and the sylvian vessels. Again, the objective is not to compare robotic scope to the operating microscope. The objective is just to show visibility and high resolution and high quality image even after high magnification, as we can see here in this case. And this is postoperative CT scan 1 day after the surgery, and it demonstrates radical resection of the tumor. Case number 3, this is the contrast MRI that reveals skull-based tumor. And here we can see that the tumor is compressing the right optic nerve. And here is preoperative MRI that demonstrates complete occlusion of the right ICA. There is small amount of perfusion in distal MCA branches on the right side. So Dr. Ahmed Spahij again performed robotic scope-assisted EDAS procedure. So here we can see the preparation of the graft for indirect anastomosis for this patient with a skull-based tumor and steno-occlusive disease. So all these movements that you're gonna see in this video are hands-free and are done with a robotic arm following hand commands. And again, we can appreciate the high quality image. And here is the final graft. And here we can see a postoperative MRI 1 year after the procedure, and we can see a reperfusion of distal MCA branches. As for the conclusion, so robotic scope-assisted microanastomosis is a revolutionary step in the standard microscopic training for young neurosurgeons, residents, and doctors who are interested in microanastomosis. In our experience, the advantages of the robotic scope are hands-on microsuturing without a need for a manual readjustment, instant depth at zooming, and precise transposition of the focus by simple head movements, resulting in improved surgeon ergonomics. That would be all from my side. Thank you very much for your attention.
Thank you, Hannah. Great lecture and great presentation, and thank you for your kind contribution for this article to be published. I will leave the comments for Professor Yoko Kato.
Okay, thank you very much, Hannah. So Hannah is the very popular name in Japan also. The beautiful name. Thank you very much. So I think in the future, very less invasive or minimally invasive treatment on patient would be the common thing. So I think in that means is robotic or microanastomosis is very, very important. I think in your future training. Beautiful video presentation in practice. So please continue your skill up. Thank you so much. So your next presentation. ありがとうございました。
Thank you,
はい、先生。
thank you, Professor Kato, for your
はい。
nice comments, and I think this is a great motivation for Mrs. Hannah to proceed with this kind of investigation and research in neurosurgery, and also to the others, Mrs. Eleonora, Mrs. Emma, Mrs. Medina. We have 2 comments or questions from the audience. First, Professor Kimura, please.
Thank you, Adi. So thank you, Hannah. Excellent, fantastic presentation. I
Thank
enjoyed it.
you.
Yeah, very, very good techniques using this robotic scope. So this is my first question is robotic scope is now commercially available instrument or not?
Yes.
Australian in product. Really?
Yes, yes. It's been in use since 2020.
2020, yeah, thank you. And also in Japan, we have 2 head-mounted display using the exoscope. So we use the Olympus, OY in my university hospital. So recently I launched to the head-mounted display. So in the actual surgery in your hospital, do you perform the head-mounted display for the actual bypass surgery or not? Thank you.
I think this is a better question for Dr. Ahmed Spahij because he is performing all these surgeries.
Oh, thank you.
Professor Kimura, thank you for your question. Actually, this was just a short trial period of the device. So this device becomes quite popular in Europe, especially lastly in Southeastern Europe. Many countries have bought this device.
Oh, really?
So what would be the advantages is actually this is some kind of hybrid device between the exoscope and the microscope. It's not pure exoscope, it's not a microscope. And we have performed a couple of surgeries with this device. There is accommodation period, of course, especially to the 3D glasses, 3D image, it's a digital image, and to the helmet, which may produce some kind of discomfort for the surgeons who are not used for this device.
Yeah,
However, I believe that in a present and a near future, this will probably be the device, especially for young surgeons, as maybe Hannah in the future or others, that they will do a normal surgery with these devices.
Thank you. I totally agree. Thank you.
You're welcome. And Professor Felletti, there is also a comment or question from Professor Felletti, so please proceed.
Yeah, thank you, Adi. Hello, Anna. Good to see you again. Excellent presentation. I actually had one question and one comment, but the question is very similar to Professor Kimura's question, and it was related to the difference between this device and an exoscope. But you already replied. You already addressed this question. My comment is that obviously, with such devices, you need to remodel your thought about surgery because you have to readjust the matching between the direction of your site of your head and the side of the surgical field. So it's a completely new conception of surgery. My question is, I noticed, of course, you need this helmet and your eyes are blind basically to the surroundings, I guess. So you can see only the surgical field. So I have never used this kind of device, but I imagine sometimes you have to look at the scrub nurse to grab some instruments or, something like that. So how much comfortable is it wearing this helmet that allows you to look, I guess, only the surgical field if you need to look at the scrub nurse? The comment is that I agree with you, Adi, and congratulations also to you, Adi, because you are giving your students such opportunities. I agree with you that new generations, like Anna's generation, will be that the one taking the major advantages of these new technologies because they have to learn from the beginning and learning from the beginning this kind of new paradigm in surgery is easier compared to older generations. So thank you very much for the nice presentation, Anna.
Thank you.
Thank you, Professor Felletti, for a great comment. And actually, this is always a question. One of the maybe complaints for the surgeons who are working with pure exoscope was that they are seeing their surroundings when they are looking at the screen. So that makes some discomfort during surgery. And this device is you don't see anything except the surgical field. Of course, that in the future, I believe that we will have to have trained team with a scrub nurse that will follow you all the time because you cannot see her. However, the glasses may be opened anytime when you want, just pressing the foot pedal and the glasses are opened, but you have to quit your surgery during that period. So that is one of, we can say, advantages and disadvantages of this device. Helmet is, for me, especially, it was making some discomfort because of it's not so heavy, it's a half a kilo, but it has some tension discomfort. You have to accommodate on this pressure on your head during the surgical procedure. Thank you.
ありがとうございました。So maybe Morisako Sensei, any comment about exoscope?
Sorry, I have no the experience of the exoscope,
okay.
so I'm sorry, I have no comment in this case.
Thank you very much. Okay, so Hana-san, thank you very much for a wonderful talk. Please continue.
Thank you very much.
Yeah, let's give up in the future. So we will invite you again. Thank you so much. So we will have 3 more lectures. So another one is Mizuho Inoue, female neurosurgeon, skull-based neurosurgeon. She is excellent skull-based neurosurgeon from Tokyo University. So today her talk is medial sphenoid wing meningioma surgery for beginners. Mizuho Sensei.
Thank you for your introduction, Professor Kato. I'm so honored to be here as a speaker today, but I'm afraid that I'm not much of an expert yet, and my talk would be too basic, as this title shows. However, I believe it might be good to hear from not only experts, but from mid-level neurosurgeon like me. So I would like to talk about what I have learned so far. So I will share my slide.
Yes.
Can you see my slide?
Yes. Yes.
Okay. So I'm in the 13th year of my career, and I aspire to be a skull-based surgeon. So after finishing residency in Japan, I had a skull-based fellowship in the University of Colorado under the mentorship of Dr. Sami Youssef. And after I came back to Japan, I learned skull-based surgery in Saitama Medical University under the mentorship of Dr. Soichi Oya. And recently, I moved to current working place and started my own practice. While experiencing skull-based training both in the US and in Japan, I realized it is so difficult to learn skull-based surgery. The number of cases is small, and the procedure is too risky and time-consuming to let the trainees to do the case. So I watched a lot of procedures, but didn't have much opportunities to actually do the case. So how can I start skull-based surgery? I think it would be ideal to start with less complicated cases. So after I became able to manage no-skull-based meningiomas like this, it's still so far from doing complicated skull-based meningiomas like this. So I needed some cases in between these two, and I came across this case. This is the first medial sphenoid wing meningioma that I have operated, and I learned so much preparing and actually doing this case, which I would like to share with you today. The patient is 67-year-old female, presented with transient motor aphasia. She didn't have any visual deficits. MRI revealed left-sided medial sphenoid wing meningioma with maximum diameter of 5.5 centimeters. The tumor attachment is lateral to the optic nerve, and the tumor did not invade the optic canal. CT angiograms show the ICA displaced medially, and the M1 stretched and is displayed upward, but not encasing these arteries more than 180 degrees. Based on these findings, I thought this case is not so much complicated. CT angiogram also showed the prominent feeder from recurrent meningeal artery. My mentor used to say copy completely what I do, so I started researching for the similar cases operated by him, and I watched the operative video repeatedly. When I watched the video of the tumor on the opposite side, I flipped the video so that I could imagine the actual operative field. Then I wrote down the operative plan and shared it with my mentor. Here I listed the surgical steps for medial sphenoid wing meningioma resection. Extradural procedures include extensive drilling of sphenoid wing, anterior clinoidectomy, and coagulation of ECA feeders. Intradural procedures include early detachment, effective debulking, and dissection from surrounding brain tissues, which are the basics of meningioma surgery, and special consideration of the tumor of dislocation include dissection from the optic nerve and from the ICA and MCA. For my case, I decided not to do anterior clinoidectomy based on the tumor location lateral to the optic nerve and absence of visual symptoms. And dissection from the optic nerve also seemed unnecessary for this case. From here, I will share what I learned from the reference cases, the similar cases operated by my mentor. For extradural procedures, extensive drilling of the hypostotic sphenoid wing is necessary to obtain wide working space for tumor detachment. This process also facilitates the coagulation of ECA feeders, namely recurrent meningeal artery in the superior orbital fissure, like in my case, or middle meningeal artery. This is a reference case operated by my mentor, the tumors on the right side. Sphenoid wing bone was drilled using cutting bar, and the diamond bar is used to open the superior orbital fissure. The feeders from recurrent meningeal arteries are being coagulated and cut. In this case, anterior clinoidectomy was not done because the tumor located lateral to the optic nerve, but there are enough space is created and the tumor is detached with minimum brain retraction and without splitting sylvian fissure. Here's the ICA and the optic nerve identified medial to the tumor attachment. These images show the sphenoid wing before and after drilling. This triangular space created by drilling facilitates tumor detachment. This is another video showing the extradural procedure, the tumors on the left side. In this case, the tumor was fed by prominent recurrent meningeal artery feeders, which are visible on the temporal tip dura here. Superior orbital fissure is opened, and in this case, anterior coronal process is also drilled. Meningeal orbital band is cut, and here prominent bleeding from the recurrent meningeal artery is encountered, which was coagulated with bipolar cautery. The roof of the optic canal is drilled to reveal the optic sheath. In the anterior coronal process is poured out, and the tip of the process is taken out. Here the remaining optic strut is also drilled and removed. In this case, middle meningeal artery was also prominent feeder. In such a case, my mentor liked to cut the superficial layer of the dura parallel to middle meningeal artery. This maneuver makes middle meningeal artery pops up and become easier to be pinched and coagulated with bipolar forceps. With these extradural procedures, enough space is created and adequate devascularization is achieved. Recent virological studies show that 90% of sphenoid-rich or olfactory root meningiomas are feeders from recurrent meningeal artery, while 60% is fed by middle meningeal artery. Therefore, opening superior orbital fissure and coagulate recurrent meningeal artery is an important step for devascularization. For the intradural procedures, I reviewed the dissection technique of the tumor from surrounding brain, especially effective use of cotton patties and suction. And I learned dissection technique from the ICA and MCA. Basic steps here are splitting the tumor above the ICA and M1 and dissecting from perforators. This video shows the dissection technique from the surrounding brain. Thick cotton putty is held with a brain retractor, and with a bipolar forceps, tumor is pulled out. Same time, a thin layer of brain tissue together with arachnoid layer is brought back using suction tip. The tumor is debulked, and the deeper part of the tumor capsule is pulled out. Now the suction tip is used to hold the cotton putty to wrap the surface of the tumor capsule. Next video shows the dissection technique from ICA and MCA. The tumors on the right side. The ICA is followed distally, splitting the tumor above it. In the posterior wall of the tumor, M1 is identified and followed proximally. The dorsal aspect of M1 to ICA is completely revealed. Now the tumor is dissected from the lateral aspect of the ICA. PCOM is identified over the arachnoid layer. And now tumor is gradually thinned out using micro scissors to preserve anterior choroidal arteries. Here's another case showing the dissection from ICA and MCA. In this case, at the posterior capsule, M2 inferior trunk is found for the first and followed proximally to M1 and ICA. PCOM and anterior choroidal arteries are identified, and then ICA and M1 is followed backward to MC bifurcation and M2 superior trunk, which was tightly adherent to the tumor capsule and dissected using micro scissors. This video from Neurosurgical Atlas beautifully illustrates the steps for tumor dissection from ICA and MCA. First, usually MCA is identified at the posterior aspect of the tumor capsule and followed proximally. And ICA is identified deep to the tumor attachment and followed distally. The tumor is split above the ICA and M1 and split it into the two pieces. Each piece was mobilized from each side of the ICA, preserving perforators. And mobilizing the tumor of the lateral side, care should be taken to not to injure PCOM and anterior choroidal arteries. When mobilizing the tumor on the medial side, M1 and M1 perforators should be preserved. Finally, this is a case I have operated. The tumors on the left side. The sphenoid bone is drilled using the cutting burr and round jaw and the diamond burr to open the superior orbital fissure. Meningo-orbital band is cut. The feeder from recurrent meningeal artery is identified, coagulated, and cut. After opening the dura, the tumor was detached from its attachment to the sphenoid wing dura. And the tumor is also detached from surrounding brain tissue using thick cotton putties. After debulking, the deeper part of the tumor attachment is detached. The optic nerve in the ICA was identified medial to the tumor attachment. Tumor was also detached from the tentorium, and the temporal part of the tumor is taken out. Here at the posterior side of the capsule, MC is identified. Here is the MC bifurcation tightly adherent to the tumor capsule. Thickened arachnoid is cut, and also small feeder from the MCA is coagulated and cut to free MCA bifurcation from the tumor capsule. Tumor is elevated and further debulked. Then M1 is followed proximally. A blade of bipolar forceps is inserted between the M1 and the tumor to cut the tumor above the M1. Here the ICA is identified over the arachnoid layer in followed distally. The tumor is depleted using bipolar cautery and also micro scissors. Now the tumor is completely split into two pieces. The lateral component is rolled over to reveal PCOM and anterior choroidal arteries. The tumor is carefully dissected from the ICA not to injure the anterior choroidal arteries. The lateral compartment is taken out, and the medial compartment was mildly adherent to the medial aspect of the M1. So this part is also carefully dissected not to injure M1 or A1 perforators. Medial component is also taken out. Near total resection is achieved, leaving a small piece of the tumor in the superior orbital fissure. I managed to complete this case with the mental supervision, and after the surgery, the patient had a transient worsening of a fissure, which later recovered completely. After experiencing this case, I felt I became more ready for more complicated cases. So here's my experience as an aspiring skull-based surgeon. For beginners, I recommend starting with less complicated cases, trying to copy mentors doing similar cases. I think fellowships, skull-based fellowships are, even if just watching, great opportunities to collect reference cases, which are the best learning materials. Thank you.
素晴らしい発表でした。先生、ありがとうございます。The excellent talk. Thank you very much, Anino 先生. So maybe I think Albert.
Yes, very, very beautiful talk and very nice technique. Thank you very much. I think a key point is how to manage the vessels in such cases with big tumors. And I agree with you that vessels should be followed from distal to proximal initially, at least, because it's safer. However, there are some people saying that following vessels from proximal to distal should be done. I remember I had discussion about that with Professor Sami during one of the Alumni Association webinars, and he also suggested to find the vessels distally first because it's safer. So I just want to give this comment that it's important to identify vessels distally and maybe safer to follow them back, at least before you don't have a good debulking of the tumor. So after a good debulking, you can safely manage also the ICA. So thank you very much for your presentation.
Thank you for your comment.
Thank you. Dr. Raja?
Yeah, thank you very much, Prof. Mizuno. Thank you very much for this wonderful presentation. Regarding the medial sphenoid wing meningiomas, if I may say that patients mostly come with a mild or moderate amount of proptosis. Okay, so the reasons for proptosis can be like because of the compression of superior ophthalmic vein, or also due to hyperostosis. So you have to deal with both. So you have to drill so much so as there is enough volume for the proptosis to resolve, as well as decompress the superior ophthalmic vein so that the drainage is preserved. These are the two main aims. But if we do not do this, that is why the post-op patients sometimes do not have that regression of the proptosis. So in your case, have you seen this element of examine this element of proptosis?
I think the patient I had didn't have any proptosis, so I didn't have any consideration about that. But some superior wing meningioma have hyperostosis of the bone, and in that case, sorry, I don't have so much experience for the superior wing meningioma with proptosis, so sorry, I can't answer your question.
Okay, thank you.
Thank you, Professor Inoue. We have also a question from the audience, Dr. Becker, who is our fourth-year resident. Dr. Becker.
Please.
Dr. Raja, may you please promote Dr. Becker as a panelist? Yeah, he's here.
Yes.
Thank you.
During that time, maybe we can ask Dr. Morisako Sensei. Can you advise or can you suggest, Inoue Sensei?
Yes, so thank you for your educational presentation. So so already very important factor how to remove the skull-based meningioma. A lot of the technique is required, but so you already learn how to manage or how to proceed step by step the procedure. So very so I think epidural procedure very important. So before the intradural procedure, so you nicely emphasize that part of the method. So I have the one question for you. So so do you usually insert a spinal drainage or the ventricular drainage or to reduce the intracranial pressure in such kind of the relatively large tumor?
Thank you for your question, Dr. Morisako. Usually for the anterior the sphenoid meningiomas, we don't usually insert the lumbar drain. And for skull-based meningiomas, the only cases we need spinal drainage is some cases that need anterior vitrectomy, need to elevate the temporal lobe or something. So just reduce the intracranial pressure. We don't usually place the lumbar drain.
Okay, so thank you for your comment. So in our institute, we usually insert the spinal lumbar drainage before the tumors, before the surgical setting. So after once we insert the spinal drainage, we can more easily expose the extradural procedure. Very easy, and so the retracted temporal more posterior side without any trouble. So that is some of the difference of your institute and our institute. Thank you.
Yeah, that sounds good. I will try it for the next case.
Thank you. Dr. Becker is with us. He's also, as I told, our fourth-year resident. He's very interested in publishing in meningioma. So please, Becker, proceed with your lecture, with your question.
Good afternoon to all of you. First of all, thanks goes to Professor Kato. She's always with us here, and we have this traditional webinar. And she was here in Sarajevo, where I had a pleasure to meet the Professor Kato. Thank you also, Dr. Adi, for organizing this webinar. Dr. Mizohu, you had a great presentation. I have one question. It is regarding the benefit of preoperative embolization of the skull-based tumors or meningiomas. Do you have experience with that, and what does the literature say about the benefits?
Oh, yeah, thank you for your question. For the sphenoid meningiomas, we usually do not do the preoperative embolization if the feeders are coming from the recurrent meningeal artery for middle meningeal artery, like in this case. But there are some more complicated meningioma near this location, like clinoidal meningioma or something. Feeding arteries sometimes comes from RCA feeders. So in such a case, we usually do, not usually, but sometimes do the preoperative embolization because they're bleeding from such feeders come encountered later in the operation, and if the feeders is coagulated in the extradural procedures, we do not use the preoperative embolization, but if not, we recommend preoperative embolization.
Okay, thank you.
Thank you very much. So maybe Sensei, thank you so much for your wonderful lecture. Please continue, because recently the more endoscopic evacuation or more or less invasive treatment is mainstream. So, but you are one of the top leader, the female leader of the skull-base surgery. Your teacher is Oya Sensei, right?
So I leave the University of Saitama University and currently working apart from Dr. Aoya. But yeah.
Okay, thanks so much.
If you give lecture from him, receive comment from him.
Okay, thanks so much. So we should promote proceed the next speaker, Nakaya Shunsuke Sensei. So he is a epileptic neurosurgeon from Fujita Health University, surgery of the medial temporal lobe and issue with lesions. He has so many experience with awake surgery also. Please.
Professor Kato, thank you very much for introducing me. My name is Shunsuke Nakae. Today, thank you very much for giving me such a wonderful opportunity to talk. Today, I'd like to talk about what surgical strategies or approaching regarding surgery of the medial temporal lobe. Surgery on the medial temporal lobe and insula is generally thought to be difficult. But I think the difficulty of surgery differs greatly between tumor and non-tumor disease. So I'd like to talk about surgery for these areas, mainly from the point of epilepsy and glioma surgery. First of all, let me talk about surgery on the medial temporal lobe. So if you see a region located in these areas, I think it is important to diagnose the presence or absence of epilepsy, because lesions in these areas are very frequently associated with epilepsy. And if seizures remain after surgery, it may affect the patient's quality of life. But second, it is also important to evaluate memory function before surgery. Basically, the verbal and visual memory are generally associated with dominant and non-dominant hippocampus respectively. After evaluating these, we will decide on the surgical approach. I think that there are main 5 routes to approach the inferior horn as shown in this illustration. The first is trans-Sylvian and transventricular approach from the back. And the second, a transcultural approach from the outside. And the third one is a subtemporal approach from below. And the fourth approach is from front. And the last one is to approach from the back. But in the case of tumor, these 5 approaches are sometimes not wide enough to remove the tumor. So when removing tumor, I often choose ATL. I'll show you the ATL surgical procedure. First, the tip of temporal lobe is removed to create sufficient surgical window to remove the lesion. Next, detect the inferior horn, identify normal structure, and reject the lesion. The posterior limit of safe resection using this approach is determined to be up to the level of this line. You can recognize here during surgery because the midline originally formed depression here. ATL is the widely selected surgery for the temporal lobe epilepsy. In epilepsy surgery, the normal structure of the medial lobe is usually preserved, and the hippocampus is often atrophied, so it can be removed even with such a small surgical corridor. On the other hand, in the case of tumor, the normal structure of the medial temporal lobe may be destroyed. the hippocampus is often swollen, and the pia mater which border the brainstem may also be destroyed. So abnormal anatomy may lead to disorientation, and subpial resection may not be safe. Next, I will talk about insular resection. Surgery for the insular differs greatly between epilepsy and glioma surgery. In both cases, the sylvian fissure is often opened wide, but in the case of glioma, the insula is often swollen. So the anatomy is difficult to understand. In addition, epilepsy surgery rarely requires deep resection. We do not need to be careful about blood vessels such as the LSA. So I think the glioma surgery is much more difficult in this area. I will talk about the sylvian fissure dissection. This is a case of a left posterior insular region. When I dissect the sylvian fissure, I usually start using 2 forceps to kill the arachnoid. After removing the superficial arachnoid membrane, I use scissors and suction to treat the sylvian fissure. If I cause bleeding through this procedure, it will be difficult to treat the sylvian fissure. So I am always careful not to cause bleeding. In area where there are no blood vessels, the brain can be removed by using scissors like a spatula. By removing the arachnoid membrane surrounding the brain that branches into the frontal temporal lobe, it is possible to increase the mobility of the brain and make it easier to retract the brain. And you can see insert cortex here, and this is the procedure we usually perform to dissect the sylvian fissure. We have experienced 24 cases of surgery of the major temporal lobe and insula since 2019. I will share some cases. He was diagnosed with a left hippocampal tumor following trauma. The patient had daily episodes of focal impaired awareness seizures, and her verbal memory was had decreased. And this is her MRI image. The hippocampus was extremely swollen, and was surgical swab with ATL. The head was fixed in a strong perfect down position, so I think the awake craniotomy is not encouraged for hippocampal tumor. So this is a surgical video. First, I dissect the sylvian fissure and expose the insular cortex. Then I dissect the proximal part of the sylvian fissure and identify the ICA and optic nerve. Next, I removed frontal tips. I found the inferior form and searched for the inner structure of the hippocampus, such as choroid plexus. But I could not find them. So I checked the PCA and the brainstem and used them as a landmark to detect the hippocampus posteriorly. I still look for the choroid plexus, but could not find in this case. The outside of the hippocampus is transected by rejecting innominate circles. And if you remove it to back, the angle at which you can see the midbrain is changed. So first is like this, and posterior is like this. I confirm that the tumor has been removed to the extent that I expected before surgery, and I confirm that the bleeding stopped and finished the surgery. In this case, it was difficult to understand the anatomy because the hippocampus was extremely swollen and the inner structure of the hippocampus could not be found. This is relatively common, but the important thing is, I think, innominate cycles is always identified. And when it is excited downward, it will reach the tentorium. There are MRI images after surgery. To date, she has spent more than 4 years with a tumor recurrence or recurrence of seizures. This is a different case. I could not find the correct plexus during the surgery in this case, but the pathological photograph shows choroid plexus that was atrophied to the extent that it could not be seen under a microscope. So it is probably caused by tumor growth. Such cases accounted for about half of the case in our case series. Next, I will talk about visual field loss. ATL often causes postoperative visual field loss. But when comparing these two cases, in the case on the right side, the approach was taken from the outside. But in this case, no visual field loss was observed. This suggests that there are large individual differences in the cause of the optic radiation. Optic radiation typically runs as shown in these images, right here. So if you want to avoid visual field loss after surgery, I usually choose anterior approach route. This photograph is on the this photograph shows the brain from the bottom, and if you look at the rhinal circles from the direction of surgery, right rhinal circles is here, and you will see this location. And if you cut this area back about 1 centimeter, you will reach inferior horn. In this case is a tumor located in the right ankle and the hippocampal head that was associated with epilepsy. I'll show you the video of the surgery, and after dissecting the sylvian fissure, the tumor was confirmed. So this is a pronoun flora. The rhinal circus is here. The tumor was carefully excised from here toward the back. So here, I found the inferior bone. You can see amygdala, ankles, and the hippocampus are connected into one. The hippocampus was removed posteriorly. And the hippocampus, finally hippocampal transections were added. These are MRI images of the surgery. He does not have visual field loss after surgery. To date, he has spent more than 3 years with a tumor recurrence of seizures. Finally, I will talk about insular surgery. As this paper showed, resection of posterior and superior insula is very difficult. It is important that how large the insula can be exposed. So in our university, we usually do awake surgery for insular glioma. This is a case in which the tumor was almost removed. So this is an insula, but it's very shallow. I confirmed that the Sylvian fissure was dissected to the posterior edge of the tumor. The patient was awakened and the placentral gyrus was identified by stimulation. The resectable operculum was resected in awake condition. And check the anatomy around here. And the tumor was carefully excised and not to damage M2. Basically, we do not use bipolar to stop bleeding deep in the frontal side of the insula. And check the depth of the rejection and confirm that the bleeding was stopped and surgery is finished. So this is the conclusion. Thank you very much for your attention.
Thank you very much, Nakai-sensei. So it was a very wonderful and very interesting cases. And the video was very easy to understand. So maybe Dr. Dilshot?
Yes. Yes, indeed, it was very interesting, Nakai-sensei. Thank you so much.
Thank you so much.
I'm also very interested in glioma surgeries and using awake procedures. In case of insular gliomas, which are like 3 or 4 grade by Berger-Sinai classification, which are large gliomas, do you use single like Sylvian fissure approach or subtemporal approaches, or you can use multiple transcortical corridors to resect these kind of tumors?
Thank you very much for your question. I tried to split Sylvian fissure as wide as possible, but usually not enough space to resect the tumor. So that's why I always choose awake craniotomy to resect the insular glioma. To resectable operculum should be resected, and we need to create enough surgical windows to resect tumor. In the case of insular glioma, I think.
And the other thing is, in the last maybe like 5 or 10 years, there is such a concept called supratotal resection. Are you agree with this kind of supratotal resection in cases insular glioma cases? Can you use extra limiting resection of gliomas using awake craniotomies?
Yeah, I think yes. So your question is awake craniotomy is better to resect insular glioma?
Yes, and the use of supratotal resection. Can you use this supratotal resection in case of insular gliomas?
Every time? You mean every time I can?
Yes, case by case, maybe.
Yeah, case by case, yes. Especially left posterior case, it is very difficult. So I think not always subtotal. Sometimes partial resection. It depends on the function of the patient, function of speech and motor function.
Yeah, and you always monitor the subcortical tracts. Yeah.
Yes. On MEP, FEP, and cortico, FCCEP, I always use.
Okay, thank you so much.
Thank you. So, Dr. Albert, do you have any other question or comments?
Yeah, thank you, Nakai Sensei. Very nice presentation. I enjoyed it. Just a question, a small question. As you mentioned, when we do mesial temporal lobe surgery, we have to pay attention to both vessels. So the importance of identifying the inferior choroidal point in those cases, and also visual defects. So do you have some tips for us to reduce the risk to the Meyer's loop, for example? Do you have some suggestions how to avoid this kind of problem?
Thank you very much for your question. I think it's very different. How to medial group is very different depending on patient. So
right.
I cannot. I don't know the. I don't know how make sure to avoid the visual field loss if I approach outside. So that's why I use the anterior approach route to avoid the visual loss. So that's the only way I know the.
I see. So, yes, I agree. It's difficult to predict. Do you use visual evoked potentials in these patients?
I never tried.
Yeah.
Because usually, how can I say English? But the visual field loss is like this. Maybe most case, visual field loss is like this. So even if you use the VEP, we cannot recognize half or
right.
So I don't use it, and I also try to a visual task by awake conditions, but I not successful so far.
Yeah. Vision is very difficult to monitor.
Yeah, very difficult. Yes,
very
difficult.
Thank you.
Well, thank you so much. So, Nakai Sensei, please continue the research and the clinical work in the future. So, the next speaker is the last speaker, Miyawaki Sensei, Satoru Miyawaki Sensei from Tokyo University. His talk is a cerebromedullary fissure approach for lesions, the near post ventricle. Also, he is the expert of Moya disease. His research is very educational. Thank you very much, Miyawaki Sensei, please.
Hi, thank you for introduction, Dr. Sato. It's my great pleasure to make a presentation at this meeting. I also do more disease work, but today I'm going to talk about cerebromedullary fissure approach for lesions near the fourth ventricle. Can you see my slides? It's okay?
Yes. Fine.
Okay. And also I will talk about our preoperative simulation using Fusion 3-dimensional computer graphic images. So the cerebromedullary fissure approach is a surgical technique used in neurosurgery to access lesion near the fourth ventricle. This approach involves carefully separating the cerebral hemispheres to reveal the underlying fourth ventricle without retracting or causing harm to the surrounding neural structures. So opening cerebromedullary fissure, firstly, we open the medulla tonsillar space. When we cut the terachoroidea to lateral, we can access to the lateral recess. In the medial route, we open the uvula tonsillar space and cut the terachoroidea and up to the inferior medullary velum. We can obtain a wide surgical approach route. So when determining surgical approaches route, it is necessary to consider the positional relationship between many anatomical structures such as arteries and veins, nerves, nuclei, and nerve fibers and the lesion. So preoperative simulation with Fusion 3-dimensional computer graphic image would be useful. Our department has been actively conducting preoperative simulation using 3D fusion images. Previously, there was a lot of manual works involved in 3D fusion of images with different modalities such as MRI and DSA. Therefore, we have created software for 3D fusion images and preoperative simulation that automates many of these processes. It's called GRID, and it's already commercialized. It can automatically perform registration in multiple images and segmentation of brain tissues such as cerebellum and cerebellum. In addition, a preoperative simulation function is enhanced. This is a case of MCA aneurysm. This is this is automatic segmentation, registration, and segmentation. So for the vessels, it is manually segmented, and this is fibers, and this is a preoperative simulation. We can retract veins and brains, and this is the aneurysm. Also, clipping could be simulated with this software. So I'll show you some illustrative cases. First case is 51-year-old male. He had 3 previous hemorrhage events and presented with ataxia of left upper lower extremities, ataxia of trunk. The cavernous malformation was detected in the deep cerebellum, and it was increasing in size in the course of 2 years. The lesion was located in the left middle cerebral peduncle to upper cerebellum. How could we approach to this region? So I will show you the process of 3D fusion images. First, the CT-MRI imaging are aligned by automatic registration, and the skull, cerebellum, brainstem, and major arteries are automatically segmented. It takes about 1 minute. Visualization of region must be done manually. MRI top images were used. The lesion is visualized by removing unnecessary parts. This is the lesion. DSA images are then used to visualize microarteries. Registration of DSA images must be done manually. Thresholds are adjusted to visualize the target blood vessels. Unnecessary parts are removed. Developmental venous anomaly, which is important in cerebral malformation surgery, is visualized using venous phase information of angiography. The cortical spinal tract is then visualized using diffusion tensor images. And dentate nucleus and cerebral fibers are visualized. Now the 3D fusion image is completed. It takes about 1 hour for this process to be done. Next, we will present the surgical simulation. In this case, we examine the cerebromedullary fissure approach from posterior side and this occipitotranstentorial approach from the superior side. First, we present the approach simulation from the posterior side. First, after the craniotomy, retraction of cerebellum is performed by brain deformation function. The floor of the fourth ventricle is exposed. Retraction of the pica and swollen cerebral. This is the cerebral malformation. And this is the approach from the occipitotranstentorial approach. So approach from the above means that the lesion exists in the considerably deeper part, and the DVA, developmental venous anomaly, was also exists in the deepest part. So based on these consideration, we chose approach from the posterior side in this case. So this is my surgical video. So opening the cerebromedullary fissure to the lateral side. This is the lateral recess. After retracting the tonsil, we can see the swollen peduncle. And we know that the region is in this part. So we could approach the cerebral cavernous conformation easily. We took out the lesion piece by piece method. And we be careful not to injure the developmental venous anomaly. The lesion was taken. I'll show you another case. This is a 2-year-old girl. She presented with severe impairment of consciousness and left hemiparesis. Cavernous malformation of the brainstem was detected in the right pons, and which tended to increase over the course of 2 months. So this is the preoperative simulation. It was a relatively large region, but we figured that we could approach to this region by cerebromedullary fissure approach. So this is another video. So we opened the cerebromedullary fissure, and also we opened the uvula tonsillar space. And also we opened the inferior medullary bottom. This is the inferior medullary bottom. We could open wider space to the fourth ventricle. We detect the facial nerve, facial cortex, and we confirm that there is no important neurological function around this lesion. We cut about 2 millimeters on the floor of fourth ventricle. We could easily access to the lesion. This cavernous malformation was relatively large. We dissect from the surrounding brainstem structure, and we took this lesion piece by piece. So this is the final view. The lesion was fully taken. So I'll show you another case. This is a cystic hemangioblastoma. The patient was 47-year-old male. He presented with dizziness increasing over time. So the main feeder for this lesion was ICA. We also did 3D fusion image simulation, preoperative simulation. So the lesion was here. The ICA was supplying vessels to the pica area. So it was a ICA. So this was ICA, and and also it supplied vessels to the pica region. So how to approach this region? First, we simulated trans-cyst approach. But if we approach the lesion from the cyst, the feeder ICA was beneath the lesion. And so I figured it was difficult to dissect from the feeder. So we simulated the cerebromedullary fissure approach. So from the cerebromedullary fissure approach, the feeder comes first, and we can easily dissect the lesion from the feeder. This is the ICA, and these are the feeders. So we figured the cerebromedullary fissure approach would be suitable for this case. And I'll show you a video. So we opened the cyst, and we made a decompression, and we could see the lesion here. But to dissect from the feeder, we opened the cerebromedullary fissure. By opening the cerebromedullary fissure, we could see this the feeder here. This is the hemangioplasma, the region here. We protect the from the first ventricle with rubber seat, and this is the lesion, and also this is a feeder. So before dissecting the lesion from the feeder, we put on the temporary clip on the feeder, and this is the tiny feeders from the ICA. So we be careful not to injure the feeder, the passing ICA, and dissect the lesion from the surrounding structures. This is the drainer, the final drainer. After that, the lesion was taken out and blown. And the ICA, the feeder ICA, this was passing through. It was not injured. We confirmed the patency of the ICA by 3D ICG video angiography. So there was no infarction. After the surgery, the lesion was fully taken. So using our software grid, automatic registration and automatic segmentation significantly reduce image creation time. Small arteries, cranial nerves, tract fibers, and are individually manualized. Information must be shared between the surgeon and the image creator as to what anatomical structures are to be visualized. Simulation functions such as bone drilling and brain deformation are very useful preoperative simulation. So this is my conclusion. 3D fusion images and preoperative simulation with grid are useful in determining the approach route for brainstem and deep cerebral region. Thank you.
Sensei, thank you so much for wonderful preoperative image and also followed by the beautiful surgical video. Albert Sensei.
Yes, Miyawaki Sensei, thank you very much for very beautiful images and surgeries. I have one comment and one question. Once again, we have seen that how much useful for a surgeon is to have a very nice preoperative plan with this kind of images. So I'm really impressed about this software that can actually show us what you will see during surgery, and you can show us, you can decide to choose one way or another based on these preoperative images. So very impressive. The question is about the cerebellomedullary route, which is actually a wonderful way to get to the fourth ventricle. Sometimes you have huge lesions, huge tumors, and they are very close to the cerebral aqueduct. And as you mentioned, you have to separate the cerebellomedullary fissure and also to cut the inferior medullary velum. But in these cases, sometimes the inferior medullary velum is deformed by the volume of the tumor. So it's not so easy to understand the limits of this inferior medullary velum. And sometimes if we cut too much on the straight line, we might injure the dentate nucleus. So, right, sometimes we have to lateralize. So I just want to ask you if you have any tips, any suggestions how to, finding some landmarks in such difficult cases when you have a huge tumor with the deformation of the inferior medullary velum. Thank you.
Thank you for your comment, and thank you for the important question. Actually, I think it will be, as you mentioned, it will be very difficult to identify the limits of the inferior medullary velum. It's in some cases it's very difficult, I believe. But so in my opinion, so not to open too much, I think it is very important. So even if you don't open that much, you can obtain wider space. So I think in difficult cases, it will be difficult. It will be important not to cut to not to upper part, just the inferior part of the inferior medullary will be important, I believe.
Yeah, and one last question: Do you operate these patients in prone or semi-sitting or lateral position?
So, in your practice, we operate this patient with in prone position. Prone position.
Thank
you.
you.
Dilshad?
Thank you so much, Miyawaki Sensei. That's a very nice presentation, and especially for young neurosurgeons who are practicing in skull-based surgery, especially, and me also in the practice of skull-based surgery department. So my question is, when you dissecting the or opening the inferior medullary velum, there is a risk of, as you said, the injury to facial colliculus, or and how do you avoid it? You just monitor, place this probe, monopolar probe, to delineate the limits of facial colliculus or any other landmarks.
So, so we stimulate with monopolars at the floor of the fourth ventricle to identify the facial colliculus. And after that, after identifying the facial colliculus, we put the continuous simulation probe. And during the surgery, the facial nerve is continuously stimulating, and so if the like the amplitude get lower, we stop, and you can see we can monitor the facial nerve function during the dissecting the tumor. So this is our technique.
I see. Thank you so much.
Thank you very much, Miyawaki Sensei. Well, I think now already maybe more than 1 hour the delay.
Thank you so much.
Thank you so much. Wonderful lectures. So
Thank you so much.
the program has come to the end. So just I want to ask the participants just one word, just some encouragement to the Bosnia and Herzegovina Neurosurgery Society. So at the beginning, maybe Albert, just one word, please.
Yes, I have had the opportunity to meet some of the students in Sarajevo, and I have seen that they are really, really committed to their studies in general, not only those who want to become neurosurgeons. So I encourage them to keep going, keep learning, especially focusing on this kind of exchange programs, both physical and online. These are very important, in my opinion. Thank you.
Please, additionally, the 3 female neurosurgeons. So they are listening.
Yeah. That's very important. That's very important. Female neurosurgeons can give a lot to the field of neurosurgery. I believe that.
Okay, thanks so much. So maybe Dilshad.
Yeah, I am also very impressed by the scale of this webinar. It covered almost all fields of neurosurgery, and the topics were very interesting and very contemporary surgical management of challenging cases. And it was very nice, active discussion. And I thank all the members of ACNS community for organization of this wonderful webinar, and all the attendees and the speakers, and especially for you, Professor Kato, and thank you so much.
Thank you, Dilshad. So Dr. Raja. So Dr. Liu.
Yeah, thanks, Professor Gato. For the Bosnian doctors, I think congratulations, and I think what importantly is keep publishing your great work. Thank you, Professor.
Okay, so Dr. Kimura Sensei. Kimura Sensei.
Yeah, thank you so much. So, and I also enjoyed so much. Excellent talk. Continue to our lecture. Continue to our discussion later. In future. Thank you.
So maybe we should visit the Balkan Peninsula in the future. Okay?
Yeah.
Kimura Sensei.
Yeah.
So Inama Sensei. Inama Sensei. Hurisa Sensei. Otani Sensei. Dr. Kauro from Congo.
Hello.
Otani Sensei, please.
Yeah. So thank you for invitation for this webinar. So I hope so for young neurosurgeon to get many information through the many presentation. But to tell the truth, however, for me that I can get so many good information, and I can get many studied today. Thank you so much. So and see you next in Tokyo, please.
ありがとうございました。じゃあ、中井先生。中井先生。
Thank you very much for inviting me such a wonderful opportunity. I learned a lot of things today, and I'm also very happy to see Professor Albert, my friend. It's been a long time since I met him last time, so I am very glad today. Thank you very much.
You visited Albert's place last year.
Yes, last year.
You had a good time with him, I think.
Yes. Good to see you again.
Yeah, to see you again.
Welcome back whenever you want.
Yes, thank you.
So Dr. Kauro from Congo. Kauro 先生。カウロ先生、大丈夫ですか？宮脇先生。
Thank you so much for letting me attend this great meeting, and I also learned a lot from the other presentation. I hope to see you in person in the future. Thank you so much.
ありがとうございました。では、井上瑞穂先生。Female doctors, neurosurgeon, skull-based neurosurgeon. Mizuho Sensei.
I was so happy to participate in this meeting today. Oh, sorry. And I was so happy to have the question from the resident in the Bosnia Herzegovina. So, and I couldn't see the face of the participants, but I believe I could send some message to the young neurosurgeon in the Bosnia Herzegovina. So I would like to see you in person too.
Okay, thanks so much. So Dr. Skilty, she is now is a fellow in Fujita Bantai Hospital. Dr. Skilty.
Yeah, hi. I'm a neurosurgeon from India and with Madam now, and she inspired me. So I was very happy to see Dr. Hana, a young budding neurosurgeon from a different part of the world. So I think we should look forward not only like Dr. Felici said, not only offline or not only online. We need to meet in any of the new conferences happening. Unless the young neurosurgeons interact, we will not know what is happening with the other neurosurgeons in different parts of the world. Thank you so much for organizing such a nice webinar.
Thanks so much. So the Skilty will leave 21st of this month. Thank you very much, Skilty. So Dr. Hana Sensei. Hana Sensei, she left. So I heard that the three lady neurosurgeons, one is Hana, of course, that she presented, and also Emma, and also the Eleonora, right? So thank you
very much, Professor. This was a huge honor for me to present in front of all of you. Thank you very much.
So much. So maybe we can see in person soon. Finally, Dr. Ali and Dr. Makil, younger colleague. Okay, Dr. Ali.
Okay, I think we may conclude.
I'm here.
Bakil, please.
Thank you, Professor. It was a big honor and a big experience to be today with you and to see and hear these beautiful lectures and to learn from this. Thank you for organizing this.
Adi?
Thank you at first to Professor Kato, who is a great supporter of our Association of Neurosurgeons. She's always there for us, and this has become some traditional Bosnian Herzegovina ACNS meeting, and hope to see you again in the future. Wonderful lectures, distinguished speakers. Also, I would like to express gratitude to Professor Felletti, who is also our great supporter, and to organizers of this meeting, Dr. Liu and Dr. Raja, who made technical performance of this great webinar, and hopefully we'll see soon here or in Japan or in India, somewhere where we can come all together. You are always invited to visit us. We are ready to host you whenever you want, whoever wants to visit us. It was my great pleasure and hope to see you soon in the future.
Thank you so much. We are very honored to have such a Bosnia-Herzegovina, the 6 times the webinar, even webinar. So maybe in the future, maybe we can see, maybe we can visit you. We can do the hands-on or workshop or maybe lectures with your team. I think the Balkan Peninsula has so many countries. I think the Greece is maybe we cannot call the Balkan Peninsula. Greece is a different.
We have a Society of Southeast Neurosurgical Society, which actually comprehends all of these countries in one society of neurosurgery, where I used to be president of the young neurosurgical section. So I know that we will have a meeting soon next year in Hungary. So on time, I will send you the invitation to come for this little congress where we can exchange our experiences, knowledge, meet all together.
Okay, so thank you so much. So maybe not only male, but also we encourage the female doctors.
Sure, of course.
Yeah, Japan is 700 female neurosurgeons out of more than 10,000. So that is very minority, just a 7-8%, even 700. So I think as ACNS, I think we can continue with some such kind of online, offline education course in between the EU and among the Balkan Peninsula, Balkan countries. So the wish maybe you can have more experience and more knowledge. Maybe next time, the more presentation from your side. I think just you can heard so many top presentation in the world today. So that we learned a lot, but we wanted to learn what you are doing now, what you need. We want to know. So that we studied about 5 hours today. So too much study today. So okay, so see you next time. Bye bye.